mostly no more it is syndrome, it is neoplasm. You have different types of myelodysplastic neoplasms. Okay. So I bring greetings from my hospital, which I joined just 6 months back. This is Bhakti Saint Sankara Cancer Center and Research Institute. Vikram is my colleague over there. This is a very large cancer. 750 bedded cancer Mumbai has AIMS, IRCH and National Cancer Institute and judges put together. So this hospital is the third largest cancer facility in the country. You can see the large building that I welcome any of you who would like to visit us. And I'm sure sooner or later you'll have opportunity to try there as a consultant, as a faculty, just like Vikram is with us. And I'm sure this hospital will grow. Right now, we have released 250 beds, and soon it is going to be a 750 bedded hospital, as in when all the beds are full. So that's the introduction to this hospital. This is run by Esteemed Sankara Cancer Foundation in Bangalore. The first hospital is in Bangalore, which is the 500-bedded cancer center, and we are larger than them. So I start with this slide. This is the first slide which classified acute leukemia. You find that there are 7 authors, 3 from United States, 2 from UK, and 2 from France. And I'm fortunate to have met 4 of them during the course of my 30 years as a hematologist. John Bennett, who is in the University of New York in Rochester. Daniel Katowski, who was in Royal Marsden Hospital in UK, who is no more. John Bennett is still living. David Dalton from the Hammersmith Hospital in London. And Charles Sultan, who is also from UK. So the French I haven't met, but all other 4 people, I had the privilege to meet them in person. So this classification gave some order to the classification of leukemia. They are purely morphology based and aided by cytochemistry. And cytochemistry was nothing but myeloperoxidase, Sudan black B, and later on we added specific and non-specific aesthetic to differentiate from monocytic leukemia. So this is our classification. I didn't go into the details. This was first appeared in British Journal of Hematology in 1976. So it is almost 50 years old. So it broadly divided acute leukemia into ALL and AML. Why was it needed? Because you treat ALL differently, you treat acute myelodysplastic. That time the concept of myelodysplastic hadn't come in. It was introduced sometime in 1981 when this was revised. So as I mentioned, the classification was entirely based on morphology and cytochemistry. So the classification that was outlined was purely to diagnose ALL and AML morphologically, aided by cytochemistry. So if you all know about ALL L1, L2, L3, AML from M0 to M7, they were all morphological entities and differentiated between ALL and AML by positivity of myeloperoxidase or Sudan black, the cytokine glycosyl. So if you look at this classification, you look at the cells that are on both sides, you'll find that they were classified based on the size of the cell, the cytoplasmic nucleus or nucleocytoplasmic ratio, and the presence or absence of intranuclear and intracytoplasmic microlesion. So that classified in ALL, L1, L2, and L3, which is every resident of pathology would like to classify leukemia based on this, even though you are in the era of genomics. Still, you would like to classify them. A lot of regulation must be healthy. But I must emphasize here that these things no more have any clinical significance. Whether you have vaccination, or no vaccination, these are all morphologists delight. But for a clinician, this means nothing. What means to the clinician and what he wants, I will come to that in my subsequent slides. Similarly, when you talk about acute myeloid leukemia or acute myelodysplastic, you have different types. M0 is that your morphology is like acute myeloid leukemia, but your MPO can be negative. How do you say that it is M0? Because those cytometry which they did later on, so that they have the myeloid markers like CD13, CD33, HLA, you have CD34, all these maturity markers and some myeloid lineage markers. You have acute promyelocytic leukemia, you have a lot of all Packard, and you have the second clinical picture. You say that it is suggestive of acute promyelocytic. In current practice, you don't have to do anything. The moment you say acute promyelocytic leukemia, you become is going to start them with ultra-retinoic acid. And what any variety is student, any other drug? Ultra-retinoic acid and so why this is important? So this slide will explain it to you as to why it is important. You see the Kaplan-Meier curve is very wide apart. And on the x-axis, you have months, and on the y-axis, you have the proportion of blood in the marrow. So morphology and hematologic remission in patients who have ALL with CNS symptoms, or those who have CNS therapy, and the morphology along with the survival from the entry of the diagnosis to the entire period of the study. So it is very important that different leukemias have different survival. Even then, L3 was worse than L1. So, moment you have a bucket morphology, which is L3, it was not very good. So, morphologically also, it was important to see this calculation in the cytoplasm intranuclear. So, if you see the evolution in diagnostic, from morphology, it evolved into cytochemistry, which formed the basis of French American British classification. Then flow cytometry was introduced. So flow cytometry further refined whether it is ALL or AML based on the lineage assignment. Today, lineage assignment is very important. The moment you see blast in the peripheral blood or you see blast in the bone marrow, you immediately subject it to flow cytometry. It will tell you whether you have CD19, CD10, you have CD79A, you have cytoplasmic PDT. All these are markers for plastic. You have CD3 or cytoplasmic CD3, it goes on the TTVL side. If you have CD19 along with CD22 or 79A goes towards the BLN lineage. And if you have the myeloid lineage markers like 13, 33, cytoplasmic MPO, 33, 34, and HLA-DR, it goes towards acute myeloid. But if you see overall in morphology, it supersedes. It is a poor man's myeloid morphology or myeloid. So the moment you see overall, you never say this is acute myeloid. So that is one morphological feature in a resource constrained country like us. You can say that this is there even before doing flow cytometry. So flow cytometry further progressed to cytogenetics and to molecular studies of molecular genetics. So the diagnostic evolution is constantly happening. So we will concentrate more on cytogenetics and molecular genetics in subsequent slides. So I mentioned about lineage assignment. In acute leukemia, you can have three arrows here. You have ALL B cell type, you have ALL T cell type, and you have AML type of lineage assignment, and you have sometimes both being present in a particular leukemia, which you call as either mixed phenotypic acute leukemia or acute leukemia of ambiguous lineage, where you can have myeloid along with lymphoid markers being positive. So sometimes you can have CMPO positive with monocytic lineage, and you also have some B lineage markers. So based on a score, you can say that this is mixed phenotypic acute leukemia or what you call as MPAL, or you can call it acute leukemia of ambiguous lineage. And we all know that if you have MPAL or acute leukemia of ambiguous lineage, the prognosis is not so good as simple AML or ALL. So why there is a need for changes in the class? I haven't come to that slide where I will show you three books of the blue book from WHO. So right now, the lineage assignment is based entirely on immunophenotyping. The cytogenetics and molecular classification has been introduced for disease characterization, for prognosis, and for risk stratification. Less stress is currently on morphology and cytochemistry. The best or the most astute morphologists may say something as acute myeloid leukemia, but on lineage assignment, it may turn out to be ALL. So your eyes may be the best camera, but what is on the cell surface, what is inside the cytoplasm, what is inside the nucleus will determine whether it is ALL or ALL. So don't be dogmatic that yes, this is the acute myeloid. Nobody can. So how the WHO classification has evolved? You had French American British classification, 1976, got refined in 1981. And then you had the first WHO in 2001, then 8, then 17, and now in 2022. So every 7, 8, 10 years, this WHO Blue Book is changing and the classification is changing. And the classification that was primarily based on morphology and cytochemistry has undergone a paradigm shift by the introduction of cytogenetic and molecular genetics studies. And you have now genomics, which defines not only the diagnosis, but also the classification and the therapeutic implications and prognostication. And the decision to treat, no decision to treat, everything depends on that. These are the three books. I haven't added the 2022. That has already shown the picture of that. So this is 2001, 2008, and 2017. So you can see that almost every 7, 8 years, you have a new classification. And it becomes very difficult for the student to remember the previous one and the current one. Still, when I go for taking the MD exam, still students will say, sir, this is the LLLC. Because that is morphology. Beyond that, he hasn't seen anything under the microscope. Then when you ask lateral question, he will say that yes, LLLC will have 814 concentration, which is the Perkin type of transfer. So these books you can see from the picture itself that you have flow cytometry added in 2008, and in 17 you have a lot of cytogenetics and molecular. So when we revised the 2017 WHO, that classification had some advantages and some disadvantages. What were the advantages? More cytogenetic and molecular markers were introduced, and that led to a lot of targeted treatment. Say you have KIT mutation, you have FLT3, ITD, TKD, they all have targets. So you treat those leukemias with those targets. Then you have specific sub-classification and prognostication based on the presence or absence of this one. And more entities have been described or being described with specific genetic aberrations almost on a daily basis. You have a new mutation coming up in AML and ALS every day. And if they are consistent, it comes into the classification. If they are not consistent and are anecdotally prognostically significant, you read the literature and treat them as per the anecdotal report. And the revision in 2007 made it difficult for all developing countries in diagnosis because beyond morphology and cytochemistry, we had nothing. Even today, I'm sure VIMSAR doesn't have a flow cytometer. Am I right? You have a flow cytometer? No? Yes. So even in 2026, VIMSAR does not have a flow cytometer, which is the fundamental of the diagnosis of AML and ALS. Complete characterization or categorization is not possible in resource limited setting. So what happens the moment you see blast in the peripheral blood or you have done a bone marrow aspirate, so a lot of blast, immediately you pack off the patient to bone, which has many hospitals which have the facility to do immunotherapy. So as postgraduate students, here in this institute does not have a flow cytometer, so it is difficult for you. So how do you learn? How does the AML look like? How does the MPAL look like? Or an AML look like? So when I came here for an MD exam some years ago, so I sold one hemocytometer printer to a postgraduate student. You'll be surprised. There is no name. I don't want to name the attorney who was there. Yeah. The MD student said, sir, I have never seen this printer. I said, what is PLCR? What is the different indices of reticulocyte? What is immature reticulocyte fraction? What are immature platelet fraction? What is PDW? What is the mean platelet volume? So they were not aware about it. So I said, but you have a blood cell count of 5-part temperature, why haven't you seen it? So I was told that the blood cell counter was put in the professor's room because along with the blood cell counter, one air conditioner comes with. So the professor and head room got the academy. So the postgraduate student had inhibitions in entering into the professor and head room to have a look at the hemocytometer or the blood cell counter. So these are realities of the Indian medical college. So whenever you put the blood into the blood cell counter, you have multiple parameters which comes out. You have the total count, you have the absolute count, ANC, you have percentages, you have reticulocyte count, which is in absolute terms, in percentage terms, everything you can see provided you are seeing it on a daily basis. And that's the hallmark of treatment in all patients, not only for hematology, but also non-hematological patients. So what happened in 22, 5 years later? So there was further refinement in the diagnostic criteria, and more stress was given on molecular genetics over morphology and cytochemistry. Today, if I ask a bright MD student, what do you see in every morphology error? He will immediately say, or she will immediately say, sir, 814 translation. Brilliant. You have done the answer. But the moment I say, do you see any other translocation? Do you find any other translocation in healthy morphology? Any of the students? Chocolates are there. I think I can give some of them. Are chocolates there? Oh, yes. Any other translocation we can see in healthy? What is there in 8 and what is there in 14? What is gene present? One is CME, another one is immunoglobulin heavy chain. So there is a rearrangement between CME and IgH. So if you do not have 814 translocation, what you have? You can have 28 or you can have 822. 8 is common. 8 is CME. 2 is one light chain and 22 is another light chain. So sometimes it's, instead of the immunoglobulin heavy chain being involved in the rearrangement, you can have light chains being involved in the rearrangement. Same disease, same empty morphology, but different location. Similarly, if I ask you, what do you get in acute chromatocytic liquid? You say that there is 15, 17 translocation. What is 15, 17? PML, chromocytic leukemia, retinoic acid receptor alpha. Do you get anything other than PML product in ATMs? Do you? क्या कोई brilliant bright student नहीं है? The one who is going to do her DM in clinical hematology. Let's hear from her. Do you get? 17. Other than 15, 17, do you get anything in ATM? Yes, you do get. You can have 517 translocation. You can have 1117 translocation. You can have that 5D mutation with the very name we had one clearly extremely poor responder to what transretinoic acid. So you do have aberrant translocation even in classical morphology. So you have to do genomics. Okay. So if you have a fish probe which will detect 15, 17 translocation, if it is not there, it will be negative. But if you have a 17 break apart probe, it will detect 517 also, 1117 also, because there is a break apart probe. So something will break away from chromosome 17 and will be found elsewhere using with either chromosome 5 or chromosome 11. morphology, same target, but 15, 17 probe is like. Okay. So several provisional entities have now been recognized as defined disease entities, which was provisional in 17, has become defined in 22. So the moral of the story is there is no getting away from molecular and cytogenetic. So you may ask Professor Al-Kasrawi, when do we get our flow cytometry? Your director VIMSAR is sitting here and listening. And I'm sure that he will appreciate that the Department of Pathology is vintage. So he has to bring a vintage department back to the current practice, which is standard of care in hematology, so that the postgraduate students get an opportunity to do flow cytometry and interpret that. So 2022, this was the seminal publication which appeared in Lithuania. More than 100 authors. There are some Indian authors also in there. And this is the 5th edition of the WHO classification of hematolymphoid. One is myeloid and the next one is lymphoid. This is lymphoid. Okay. So that's what happened. You started looking for the changes. There are significant changes. Nothing but MD, and now, sorry for my writing again, yes, I should have done it MDL. So you have BLL, where you found high hyperdiploidy instead of hyperdiploidy, which is what? It is only cytogenetic. Either you do conventional cytogenetics by VIMSAR banding, or you do a fish probe counting, where you will have large number of extra chromosomes in this brain. So hyperdiploidy becomes high hyperdiploidy. So if you have high hyperdiploidy, more good is the prognosis rather than just hyperdiploidy. Molecular subtyping assign more preferences over cytogen. You have large number, I will show you that slide. And when it comes to TALL, you have added ETPALL. What is ETPALL?
Early T-cell precursor.
Early thymocyte precursor, acute lymphoblastic leukemia. This is a TALL type, but exactly not TALL. There are some early precursors. So if you compare the treatment and prognosis between the two, ETPALL will be a little worse than classical TALL. The best thing that could happen was that previously you were counting how many blasts are there on this slide. And the moment you counted 20 blasts, 20% blasts, amongst the blast count, you said it is acute. And if you feel that it is myeloid in morphology, you saw some outdoors in a couple of them, you say that this is AML because blast count is more than 20%. Now 20% is done away with. Even if you see 5%, you can say AML. Even if you see 10%, you can say it's AML. Even if you see 6%, 5% is the cutoff. 0 to 5% is the normal blast count in a one aspect. So 6% blast, 7% blast. Will you call it AML? And is Trivikram Panda going to treat? Trivikram, will you treat with 6% blast?
Yes.
You would treat in certain conditions. I'll come to that. The 20% blast count is only relevant when you have BCR-ABL1 translocation being present in that AML. 1% of AML will have BCR-ABL1 translocation. CVPA mutation is another where you would like to have more than 20% blast. These are the two conditions where you need to satisfy that there are more than 20% blast. Already AML. Rest all under 20%. So AML could be classified as the AML defined based on genetics and AML defined by differentiation. Why these two entities have been given? AML defined by genetics is for developed countries. AML defined by differentiation is for underdeveloped countries. Because you don't have genetics. So what will have for you, all acute myeloid leukemia are not otherwise specified, NOS. You have NOS in many other diseases. So you will say that since I don't have cytogenetics and molecular genetics, this is AML because this is NPO positive. And I don't have the facility of doing cytogenetics nor molecular genetics. This is AML NOS. You have no other way to genetically classify. On the earlier side, it was renamed as Myelodysplastic Neoplasm, no more syndrome. So don't use syndrome anymore. It is MDN. I should have corrected it. Again, the MDS is classified based on genetic abnormalities and morphology. Same as the ML. No change. And what more were added was few entities called as seekers, zikers, riders with MDS and MDS. You have an entity called MDN, MDS, myelodysplastic neoplasm and myeloproliferative neoplasm. You have myelodysplastic neoplasm, and you have clonal cytopenia of undeterminate significance. You have idiopathic cytopenia of undeterminate significance, and you have idiopathic dysplasia of undeterminate significance. Because when you see this slide, many times you find some dysplastic change, but there is no cytopenia. Sometimes you see cytopenia, but you don't have dysplastic change. So these are the entities that will go into it, but this is not as simple as I am saying. I will further qualify it in my subsequent slides. So this is the myelodysplastic syndrome as it was classified way back in 1985 by the same French-American Pradeep group. It had 5 entities. All are refractory anemia with VIMSAR blood, refractory anemia with excess of blood, refractory anemia with excess of blood transformation if it is more than 20, less than 30 doses, and chronic myelomonocytic. This is the prototype of a classification that was followed in 1985. So here it is 2017, which is almost 25 or 22 years later. Just the classification that you're currently following. It has multiple description, multiple entities, where the dysplastic lineages are either single or bilineage or pan or trilineage. And you have cytopenia, either single linear cytopenia or bilinear cytopenia, only anemia. You can have only neutropenia, you can only have thrombocytopenia. And blast count, which will vary between more than 5% and less than 15%. And bone marrow and peripheral blasts, we already have in this table. They are more than 5% and less than 20% in this 2017 or less than 19%. So it's all about count. And when you count, it is morphological count on the microscope, not on the flow cytometry. Flow cytometry is only for linear assignment. Counting is under the microscope. Never confuse that. And always when you do the counting, what percentage in the flow cytometer, it will be lower than the manual count. Because when you do the processing for flow cytometry, there is cell loss in multiple steps of washing. So what you are seeing 20% in manual count, maybe 12% in flow cytometry. So flow cytometry is never the count that is valid for classifying as acute leukemia. So you must remember that. So features of dysplasia, cytopenia, I think Pradeep has already showed this slide. It is the same, this erythropoiesis, this granulopoiesis, this megakaryopoiesis. All of you know that. In the exam, when it is asked, you will rattle it out. When I see blast, which is a normoblast, which has got irregular cytoplasmic water, which has got irregular nuclear water, it has nuclear budding, it has got multinuclearity, it has megaloblastoid features, and cytoplasm source that on iron stain there are ring sideroblasts. All these are descriptions on morphology. In MDN, it is still relevant because after all, you have to describe dysplasia on the basis of the microscope. But again, that is changing. Now you have flow cytometry based dysplastic features. You have certain CD markers which will be either absent or overexpressed in dysplastic cells. So 2022 has introduced flow cytometry based dysplastic features. You get CD15 in all neutrophils. So if there is loss of CD15, there is dysplastic feature. CD10 is universally present in all neutrophils. You have loss of CD10, is a dysplastic feature. So all these things you can look at when you do flow cytometry. This slide was shown by Sunanda, cytopenia, hemoglobin less than 10, platelet less than 100,000, and the absolute neutrophil count of less than 1,800. This has changed. So WHO 2022 has changed this to hemoglobin less than 12 grams, platelets less than 150,000, and ANC of less than 1,500. Okay, so these are the changes that have happened. Use of terminology called myelodysplastic neoplasms. Cytopenia definitions adopted for consistency across speakers and MDN and MDS or MDN MPN. So recommended threshold. So you may say how many percentage of normoblasts should have dysplastic features. Now everything is set at 10%. Previously it was 20%. Now it is 10% of negative. So recommended threshold for dysplasia is set at 10% for all lesions. 10% of normoblasts, 10% of myeloid cells, and 10% of megakaryocytes. And this MDM has been grouped as those having defining genetic abnormalities, which I have already had, based on the facilities that you have in your lab. Otherwise, everything will be morphological. So morphologically, you'll say it is myelodysplastic neoplasm within bracket morphologically defined. And that Dr. Srivindam Banda will accept. He will understand that the lab has defined it morphologically and will accept it and will start treatment. Or before that, he will send it to some other lab for genomic definition. Even you don't have that. So it is a repetitive slide. Again, I have said that it is MDS with defining genetic abnormalities, MDS or MDN morphologically defined. Last count still is relevant. But there are certain qualifications to this. If you have certain genetic abnormalities, which is AML defined, it will not remain as MDN. It will be acute myeloid. Suppose you have a myelodysplastic neoplasm which has 821 translocation, 7% blast. What is it? Right? Pathology does it. Yeah. That's acute myeloid leukemia. If you have 821 translocation, even if your blast count is 7%, 8%, it is acute myeloid leukemia. That is the power of genomics. So you youngsters, I am motivating from here from this podium that you must concentrate on genomics. That's your future, not the microscope. Tomorrow you may say that now we have digital pathology. Now, as per US FDA NCCN guidelines, you can diagnose ductal carcinoma in breast or adenocarcinoma in the prostate without a pathologist even having looked at whole slide imaging of prostate and breast will diagnose, give the diagnosis. That is accepted. So digital pathology is coming up in a big way. That is another area all of you should concentrate. Okay. So here it is important. You look at the number of blasts that you want to know about. You look at the cytogenetic. She mentioned about 5q minus disease or syndrome. You have monosomal karyotype. You have monosomy 7. You have monosomy 5. You have absence of 5q deletion, monosomy 7, complex karyotype, anything more than 3 abnormality. It's called complex karyotype. Complex karyotype, poor protocol. That is the reason why you are doing conventional cytogenetic. Usually complex, if the cytogenetics is, it is bad. You can say that the progression-free survival, the overall survival, to the best of treatment, mostly it leads with ascites and veritoclasts in most patients will not be as close. If you have these abnormalities. SF3B1 mutation is good, provided it is alone being present. It is usually present in refractory anemia of ring sideroblast of the previous classification, or you can have it MPN with low blast and SF3B1 being positive, in which you get ring sideroblast. Ring sideroblast has always been a good morphological feature. 2 or more TP53 mutation. What is TP53? You know what is TP53? It is the policeman in every set, which protects you from all injuries. TP53 is mutated, which is present in chromosome number. Which chromosome it is present? The best student of the batch. Chromosome 7. Who is that? Yes, chocolate. Okay. Also chocolate. No. So TP53 is present in chromosome number 7. So you may have a TP53 deletion cytogenetically, but you may not have the deletion cytogenetically, but you can have TP53 mutation. And if it is biallelic, means both the alleles are showing mutation, it is not good. So you must look at molecular genetics. Then you have a terminology called loss of heterozygosis. What is loss of heterozygosis? Please read it. If I am your examiner, I am going to ask, what do you mean by loss of heterozygosis? It is not just relevant in hematology, it is relevant in solid tumors also. Copy neutral loss of heterozygosis. Means your copy numbers are same, neutral, but you have loss of heterozygosis. What it means. Okay? So you must know what is loss of heterozygosity. Often it will come in your discussion. This is a chart which will show you the correlation of 2017 and 22. And I have introduced a term called ICC, International Consensus Classification. This is called the politics of hematology. You know, the people, those who are included in the WHO group, those 100 people. And there were many who were previously in 2017 classification. That had cut off. We were there in 17, but this time they haven't included us. So they formed the International Consensus Classification. and postulated their own thoughts about classification. Now there is a truce. I am told that they have joined together and now there is consensus, and WHO 2022 has minor changes as per their wishes, and there is no ICC right. But for almost 3-4 years after 22, this is almost 4 years after 22, they had ICC, which they have now decided to come together and a common classification is there. So I will not go into this complex slide. Everything relates to something of 2017 to 2022. You can read it from the blue book. And every postgraduate resident should buy the original WHO blue. Pictures are fantastic. You will save money by xeroxing it, but you will not get the same feel of it. Few thousand rupees, doesn't matter. You go to Sambalpur and watch a movie, it's more expensive than buying a WHO group book. Okay? Buy the original one. Recommendations for cytogenetic analysis and MDI. This is the ICMR consensus document for management of MDS 2019. I am the chair of this subcommittee on MDS of ICMR. I'll show you that book. Anybody is interested, I can give it. So what we recommended, 8 of us were in that group and I was chairing it. Cytogenetic analysis performed on bone marrow sample at the time of diagnosis at a center institute having requisite expertise and resources. You may have a cytogenetic lab, but if you are doing just 5 cytogenetic samples in a year, you can't be the best. You have to be doing 5 in a week. So more the samples being analyzed, you become more expert. You need at least 20 VIMSAR banded or banded karyotype or metaphase. Otherwise it fails. Unless you have examined 20 metaphase on VIMSAR banding, these cytogenetics will fail. So what has replaced conventional cytogenetics? Right, students? More chocolates will come. You have microarrays now. High density of microarray, which is DNA based. It will give you exactly the same information what conventional cytogenetics is. No failure. Every sample will have a. So that is coming. It is expensive. Many labs have replaced conventional cytogenetics with high density microarray. Detection of MDN associated abnormalities, I have already highlighted. 5q minus, monosomy 7, 7q minus, trisomy 8. You can have chromosome 18 loss or 18q minus. 20q minus is very common. Complete loss of chromosome 5. Y chromosome loss. Y chromosome loss is very common. And particularly the patients who are in their 70s may not have their Y chromosome. I may not have my Y chromosome. So Y chromosome loss is very common on age. But if it is a young patient and Y chromosome is lost, it is good prognosis. Y chromosome loss is not bad. Presence of recurrent cytogenetic abnormalities in AML, as I mentioned, 821, inversion 16. You have 15, 17 diagnosed as AML, even if blasts are less than 20. Okay, if you have inversion 16, 8% plus AML. The clinical hematologist has to treat. Fish analysis. Fish analysis is easier to do than conventional cytogenetics because you are using a probe. The growing the cells, harvesting the metaphages, counting them, analyzing them is more cumbersome, more tedious, and it is highly knowledge intensive. The learning curve for conventional cytogenetics is high. Whereas fish, by 2-3 months of training, anybody can do. So fish should be performed at a center institute having requisite expertise and resources. And this panel should include at least 5 probes for MDN, 5q, chromosome 7, trisomy 8, 18, and 20q. So this is the difference between the two in nutshell. I have already mentioned about SFTB1. So sometimes what happens, in spite of your best effort, you are not able to classify either morphologically or genomically. So WHO has given you an escape route. You write unclassified. MDN slash MPN or MDN alone, not able to, you are not able to classify, right within bracket, NOS bracket, unclassifiable. And if you do genomics, I would like to mention that only about 50% of patients of MDN will have some genomic alteration. In 50%, you will find nothing. So this NOS unclassifiable will still hold, but if you are doing a genomic test, that may define if you have not found anything morphologically. I will not go into the details. CMML has been classified as CMML 1 and 2, even previously. Before 2017 and 2008, also you had CMML 1 and CMML 2. JMML has been removed. Juvenile myelomonocytic leukemia. MDS MPN with neutrophilia is the new name for atypical CML. Previously, you had atypical CML, which was BCR-ABL negative. Now, this has been replaced with a term called MDN MPN with neutrophilia. MDN MPN with ring sideroblast and thrombocytosis remain, but it has been redefined along with SF3B1 mutation. So SF3B1 mutation is sine for ring sideroblast. The moment you see ring sideroblast, whether 5% or 15%, if you have SF3B1, just accept that it is ring sideroblast. So I will move to save time. Somebody here said that you can have morphological hallmarking dysplasia, you can have primary or de novo MDN, you can have secondary MDN in many conditions, including megaloblastic anemia. You can have any autoimmune disorder, SLE, rheumatoid arthritis. You can have dysplastic changes in myeloid and erythroid. So they are secondary features. Now I have come back to the classification which is there in the WHO group. Previously, I had shown you 10 grams, less than 10 grams. Now it is 13 grams. I had shown you 1.8, it remains 1.8, and I had shown you 100,000. Now it is 150,000. And cytopenia and at least one hematopoiesis. So you can have only anemia, you can have anemia, you can have thrombocytopenia in isolation. So what happens? What is the problem? How to diagnose ITP when you have isolated thrombocytopenia? So the brightest student here in the audience, how you differentiate MDN with isolated thrombocytopenia from ITP? Macro. No, in ITP also you will have reticulocytic hyperplasia. Small, medium, large, all types you can find.
So in ITP, large platelets will be seen.
In
ITP, giant platelets.
MDS you will have.
MDS, MDS.
Many times it may be difficult to differentiate it from ITP. But if you have a genomic signature, your job is so. Okay. But yes, you will have problems. Isolated thrombocytopenia with MDN. I will skip this. You all know about it. How to say what is this erythropoiesis, this gametopoiesis, and this erythropoiesis. This you have to be perfect. Because there is no excuse if you don't know them. These are some of the pictures. You can find nuclear dressing, great cerebroblast. You can have megaloblastoid appearance. You can have multi-mutation also be there. You can have megakaryocyte dysplasia, which is looking at your eyes. You can have micromegakaryocyte, which is a classical hallmark in 5q minus. Large number of megakaryocytes, classically seen in female, and micromegakaryocytes, monolobate megakaryocytes. Granulocytic dysplasia, you can have internuclear bridges. You can have retention of nucleoli, even to the stage of metamyelocyte or myelocyte. You see, you have a nuclear line in a promyelocyte. The same is retained in a myelocyte to this stage. If the same is retained in metamyelocyte to this stage. Okay, you must know that. The approach. How do you approach? Unexplained cytopenia is the first diagnosis that the patient comes to with. Rule out secondary causes. Already someone has said about that. Patient should be fit for investigation. So that bone marrow morphology iron chain is very commonly done to do it. Cytogenetics is plus minus based on your availability. Molecular profile is okay. I will not go with it. This I have already described. Changes in MDM. This is all done. This is the book that we published in 2019 in the Council of Medical Research. We are going to revise it this year. We are already on it. So this is the consensus document for MDS diagnosis and management. 2019. I am the chair of the subcommittee of ICMR, and we are working on the changes as per the 2022 plus. So MDN defining cytogenetic abnormalities. I have mentioned there are some unbalanced abnormalities, some balanced abnormalities. You have some of these which are AML defining, like 321. Very bad AML defining. You have, as I mentioned, there are a large number of 1, 3. You can have 517, 57. You have deletion 11q. There are many abnormalities which are quite rare but are common. Common cytogenetic alterations in MDS is to your left. And the frequency is also mentioned, very common 5q minus followed by monozomy 7 or 7q minus, followed by trisomy 8 is also very common. Same book, right? So I will now talk about a little bit on the somatic point mutation in MDN. You have different category of mutations present in myelodysplastic neoplasms. I have already mentioned that approximately 50% of patients of MDN will have an abnormal karyotype, and rest 50% will be normal. And more than 45 recurrently mutated pathogenic somatic genes have been identified in MDN. Point mutations might accumulate over time. As the natural history progresses of the disease, you can have more point mutations. There are different categories: splicing site mutation, DNA methylation, DNMT3A. You can have histone modification. You can have transcription factor. You can have P53 pathway mutation. All are there, and these are to be studied. ETB6 is a very common mutation. The next one, T1, seen in 821 translocation. ICC, I have classified it here. ICC 2022 and WHO 2020. This no more is relevant because there is a truce between the two groups and we have a consent. Clinical and genetic continuum between MPN, MDN, and AML. This is European Hematology Association recommendation, where you have different mutations present in. You see, this is overlapping between each other. And in the center, you have MDS, MPN, or MDN, MPN overlap syndrome. Sometimes, as I mentioned, you will not be able to classify them appropriately. So write NOS bracket unclassified. So I mentioned about the ICAS, CCAS, IDAS, all those things. So this is nothing but clonal hematopoiesis. In that, you can add something called AIDS-related clonal hematopoiesis. As you advance in age, you can have a small population of clonal cells in your bone marrow, provided you are doing a very high, what you call as high definition genomic study, where the depth of genetic study is more. Otherwise, you have VICA's only cytopenia, shift, clonal hematopoiesis of indeterminate prognosis, somatic mutations could be seen, and where it is to the extent of 2%. So your limit of detection should be very good, and you should be able to show that you have abnormalities. Like here you see cytogenetic abnormalities you can find in low risk MDS, MPN, and sometimes plus minus in CCAS, ICAS, and IDAS. So the more you practice MDS, these things will be just like your routine practice. Otherwise, you have to refer to the books. These are the commonly mutated genes that MDN and CHIP. Large number of them are listed. NRAS is very common, which are called rasopathy. NRAS, KRAS is very common. You have DNMT3A, SF3B1, IDH1 and 2 is important because these days you have targeted drugs against IDH1 and 2 mutated hematological malignancies. GATA group of mutations, GATA1, GATA2, which are transcription genes, are also very important. Progression of clonal hematopoiesis into malignancy does happen. So you have 2% to begin with, it can progress. Just like you have MGUS, you can have this, and this can progress over a period of time. Progression is approximately 0.5 to 1% per year. Same as MGUS. Clonal evolution, you have to study. When you have ARCH, if you have coronary artery disease, it has been shown that if you have age-related clonal hematopoiesis, the prognosis is not. This is a model demonstrating the evolution of CHIP to AML, very complex. I'm not going into the details, but you should know that there is a model as to how this CHIP evolves into acute myeloid leukemia. Over a period of time, this is the flow diagram, shift to CCAS, no dysplasia, CCAS with dysplasia, and MDN. I'll show you the last portion of the slide. This is MDS Foundation. This is the 11th International Symposium on MDS, which happened in Edinburgh, which I happened to attend in 2011. Why I'm showing you this, you will just see in the next few slides. So there was a workshop in which I participated, 20 hematopathologists participated. And the theme of it was evaluation of dysplastic features of granulocytes and MDN or MDS and AML. You can see the picture. You can identify this lady. Anybody identify this lady will get a chocolate. This is Barbara Bain. Have you seen Barbara Bain? This is Barbara Bain from St. Mary's Hospital in London. So this is the same, and this is what we were required to score. On the screen, something will pop up, then we have to score them, and in that, then there will be mean, rank, and gender, and then they calculate it. And can you identify this gentleman? This is John Bennett, the chairman of the French American British Group, who is in the University of New York in Rochester. He is the chair of the FAST classification. He was also there. So this is the type of slides that were shown to us, that we were scoring them. And this is exactly what is happening. This is the group I was taking the picture. This is Professor Nosdringa, Germany. So you know what happened in that workshop? So we were shown some 25 cases, or maybe more, about 30, 35, 50 cases. The consensus was 60%. the inter-observer variation was so high that the consensus within the group was just 60%. So myelodysplasia is not a simple thing. What you say as dysplastic, I pronounce it as dysplasia and vice versa. So somebody who is an expert in myelodysplasia sees such cases every day, they will be in a better position to say that whether there is dysplasia, rather than somebody who is seeing 5 cases in India rather than 50 cases. So consensus between individuals have to be good. And that will come only with experience. You have three potential therapeutic drugs. Monitoring effectiveness of therapy in post-LO HSCT, technical validation and standardization and interpretation, reporting of ideas is very, very important, and good molecular laboratories must be there. So this is the NGS lab at my previous hospital at Burla Medical Center, which this young lady is going to go. So this is one of the most advanced centers in the entire Eastern India, which has 4 next generation sequencing platforms, which performs all the myeloid malignancies. There are 69 in panel. I'll show you that. I think I don't have that, and I always saw this slide. Where are these people? These are the people who are the Indian soldiers who are in the Chinese border. This is where the fighting between the Chinese and Indian happened. Okay. But you see, they're so happy. They're staying there for almost 2-3 years. One state. You may consider it as a tourist spot, but you will not feel like staying there for more than 5 nights. It is so bloody cold. The minus 40 degrees. So with that, I thank you all for a patient hearing. In case you have any queries, yes.
So nice presentation about this, but I didn't want to. I like the MDS
MDS patients and sickle cell anemia. So when you have sickle cell disease, you will have sickle RBC. You can have the presence of sickle cells in the bone marrow, you can have it present in the peripheral part. So they all come out of the same normal class.
What is clonal? Is the clonal preposition recently in the high risk developing into
See, hydroxyurea increases the fetal hemoglobin level in the RBC. And the increase in fetal hemoglobin in individual RBC are protective to CT. That's the rationale of giving hydroxyurea. People have used 5-cytidine also in this. 5-hydroxybutyrate also have been used. I am not the best.
Because this don't, it's like, so
I
any
understand.
person can go for the research work in that.
I know this is the sickle cell center of the country. Mohanty is here. He is the best person to answer your question. So I have little experience in both. The patient has got MDN plus sickle cell disease. Yes, this could be age related. If you can have a sickle cell patient who lives up to 70 years, may have MDS alongside his sickle cell disease.
How to proceed for the research work with the sickle patient here?
Then you have to do genomic study. If you can find some AML related genomic changes, you will be sure that yes, he has myeloid disease. You see, we have a myeloid gene panel of 69 genes, which has got 29 RNAs 29 translocations, and we have 14 locations. 17 of them are targeted and 23 of them are wholly. It is working beautifully well, and we do accept chronic myeloid leukemia. In my previous center, except CME, we are doing myeloid team panel for all patients of myeloid
Or you
minus CME.
you can refer to you.
It can be referred to Tata Medical Center here. At the present moment, we don't have molecular lab in PCS center, but we are gradually developing that. We have already acquired a 3 real-time PCR platform. Just recently, we are going to get a Sanger sequencer in a month's time, and we will have NGS also by the end of this year. So we are setting up our genomic lab is under construction. So I think in another 2 years, we will have a full-fledged genomic laboratory and practice in the term.
I have widely covered the topic. He has also represented our world police. I'm very grateful to the parents speech. They all here.
I wanted to inspire before that.
Thank you for such a mesmerizing speech and elaborating everything about the updates of MDS and MDN. I request Professor Dr. Murmu ma'am to present the memento to the person. Thank you, ma'am. A small announcement before going to the next scientific session that the delicious dinner is awaiting for everyone. So I request all the delegates to kindly have the dinner and then proceed. Uh, so we now move to the next scientific session on management of MDS, recent advances from case-based perspective by Dr. Sri Vikram Panda. It is my pleasure to invite Dr. Sri Vikram Panda, consultant hematologist and bone marrow transplantation, to throw light on the management aspects of MDS along with the exciting cases. So, before he presents his cases, let me tell about him. A very dynamic personality, and being a colleague, I know him personally, and Dr. Sri Vikram Panda, MBBS from VSS Medical College, VIMSAR, and MD General Medicine from LCV Cuttack. Then He has done DM Clinical Hematology in AIMS, New Delhi. Currently serves as consultant in clinical hematology and bone marrow transplantation, Bhakti Sri Shankara Cancer Center and Research Institute, Bhubaneswar. Prior to this, he worked as consultant hematology and bone marrow transplantation, Arvinis Hospital, Gurugram, as consultant in the Rajiv Gandhi Cancer Institute and Research Center, New Delhi. His areas of special interest in acute leukemias, lymphomas, bone marrow transplantation, in leukemias and aplastic anemias, including multiple sclerosis. He has many national and international publications and has presented papers at national and international forums. He has 45 publications and 35 citations. And with such dynamic personality, I invite Dr. Pradeep Burla to present his case. Thank you.
I request you to give it up to deliver his talk. We are all interested to.
So, thank you so much for this kind introduction, basically. So, I actually like to share some memories actually, Pragya. So, during the actually MD medicine day in SU Medical College, Qatar. Okay. Uh, we have actually formulated a team. C from Department of Pathology and me and Dr. Gopal. And we had actually cracked this quiz, state level quiz, and represented Odisha in Kolkata at Hotel Deep Park. I can remember. Okay. Which was, I can say, one of the actually pillars for which actually I was being motivated for hematology and hemato-oncology, and the team was actually quite good. Team to actually tell us the pathological aspect, and Gopal actually used to tell me the transfusion aspect. I tell the actually critical aspect, and we actually learned a lot from each other's experience. And till that actually till then, from that day actually we were in touch. Okay, so nice to see you. Thank you. So again, respected director sir, and our principal sir, Mr. sir, and Alka ma'am, and Murmu ma'am, and all the respected dignitaries, Sunanda ma'am. Actually, it is my privilege to actually talk on the recent management and advances as far as the clinical management of myelodysplastic syndrome is concerned at my alma mater at BSS Medical College, Burla. Again, okay. So, since Sir has actually told from his own experience, most of the students and faculty here are from pathology, I feel, and that deliberation actually from a person who has taken pathology from his choice, okay, can be well uh, held from his talk only. Okay, so he is actually a living WHO book, I can say. And this talk was actually much needed. So I'll actually just elucidate what are the clinical aspects, because aside me, Dr. Ramchandani was there, and he was telling what medicine actually will give, what thing actually will do, what thing actually from a clinical perspective. So that only I will highlight in 10 to 15 minutes maybe, and we will wind the discussion so that we can move on the next topic. Okay. So before that, who will do that? You want to move on?
That is personal. That is personal.
So before actually telling the clinical aspect and management of myelodysplastic syndrome, let me actually introduce what is actually hematology and what we are actually doing at practice is under Cancer Institute, okay, research center and Bhubaneswar. So this scientific study of the cause, prognosis, treatment and prevention of diseases related to blood and blood forming organs, it is known as hematology. So during our MBBS career, as all of us know, hematology is one of the most neglected subjects. Okay, as far as medicine is concerned, we never know. Even after even during sitting at final MBBS exam or during our MD medicine exams also, how to actually write a question as far as acute leukemia, lymphoma, myeloma is concerned. So this is actually grossly neglected part. Okay, no seminar, nothing, no classes also we conducted in hematology. But just you see the advancement, the FDA and the EMA. Okay, targeted therapy. Around more than 50% of the targeted therapy or cellular and gene therapies in FDA and more than 50% from the EMA. It is approved for hematology. Okay, just it is hematology, not oncology even. Oncology is a separate portfolio. So from this particular subject, from a particular picture, you can see actually with how what is the base with which actually hematology is being doing. Okay, so hematology, ophthalmology, neurology, gastroenterology. So now, as Sarah already told, we have actually moved from the era of actually morphology to genomics. We have moved from the era of actually as far as the clinical perspective is concerned, from chemotherapy to targeted therapy or immunotherapy or bispecific antibody or cellular therapy or gene therapy. Okay. So coming to the different domains of clinical hematology, deals with the benign hematology and malignant hematology. With benign hematology, deal with all cases of anemia, thrombocytopenia, bleeding manifestations, coagulation, thrombosis, Myelodysplastic syndromes. Okay, and with malignant hematology, leukemia, lymphoma, and multiple myeloma, we deal with actually bone marrow transplantation, autologous bone marrow transplantation, and allogeneic bone marrow transplantation, and we do actually CAR T cell therapy also, and immunotherapy, cellular therapies, and recently actually gene therapy has been also approved as far as hematology is concerned. So these are actually different clinical presentations. So so this is our setup basically. So this is our team. So we have actually dedicated hematologist to me with Satupal Mahapatri also there. So we have actually a team of hematopathologists and the transfusion medicine department, infection control department, then clinical pharmacologist, infection disease specialist, ICU and medical care team and a nursing team actually. We work like a team basically. And this is a BM team. It is one of its kind in Eastern India, a center of excellence, you can say. So it is a 10-bedded BM unit, 10-bedded adult BM unit, and 4-bedded pediatric BM unit under Department of Pediatric Oncology. All the rooms are actually HEPA filter with positive pressure rooms, HEPA filter and enable. And we perform actually both autologous and allogenic gastric and haploidentical stem cell transplantation at our center. This is the actually daycare and this is the ward you can see. And again, this is the pediatric oncology unit, this is the ICU, and this is, as you can see, I have done this institute at February 2025 last year, and on May 2025, actually, our BH unit was inaugurated. This was the day of inauguration, and this is the first stem cell transplantation which we are actually doing in a case of multiple myeloma, a case of actually autologous bone marrow transplantation. Actually, we have done actually many transplants, but this transplant will be actually specifically memorable for me because doing transplant at a new center with a new team from day one actually was a very much challenging. And the initial 5 to 6 transplants, even on few transplants now also, we have to do night duties also. Okay. And subsequently, this is the second case. We have done actually bone marrow transplantation in the case of the last Hodgkin's lymphoma, was actually received LDP chemotherapy, subsequently received TDP followed by transplant. Now actually receiving actually removal of maintenance after autologous bone marrow transplantation and completed 12 cycles of maintenance. And again, in case of multiple myeloma, then these are 3 cases of actually transplant which we have actually done outside at the Rajiv Gandhi Cancer Institute. That is a case of actually sickle cell disease, a case of thalassemia, a case of sickle cell disease from Uganda, from Algeria, and a case of actually, I was telling actually HLH, congenital HLH, familial HLH, purpurine gene mutation. See here, maybe from Iran, you see, with purpurine gene mutation, and we have done actually haploidentical stem cell transplantation from his father. A case of again relapse refractory B-cell acute lymphoblastic leukemia, aplastic anemia, multiple myeloma. So all these are actually the different things. So as far as the current status, yes, lack of awareness of basic hematological disease is there. Lack of infrastructure is there, but many more infrastructures are coming in Odisha, and the awareness among the physicians as far as hematology is concerned is increasing. Cost is a barrier, but we are actually overcoming that. We have actually many schemes, protocols, we are doing, everything we are doing actually. So currently, if we can do, we have not yet started because we are still searching for the suitable candidate. Then I would have disease again. It is already existing leukemia, lymphoma, hemoglobinopathy, anemia. Just we need to understand the subject and the proper awareness. It's actually the need of the hour. We are actually trying our level best to actually engage us with the community and traveling actually to different rural parts of actually Odisha also to actually make them our predict hematology. So involvement of all is actually required. We cannot do. So that's all. So now actually I'll please start my topic, that is the English topic. Actually, very brief, maybe finishing within the 15 to 20 minutes. Okay. So, so this will be actually the outline of my talk, that is basic introduction, then classification of the myelodysplastic syndrome, as Sarah has already told, the clinical presentation, diagnostic evaluation, risk stratification, treatment goals, supportive care, then management of low risk MDS, high risk myelodysplastic neoplasms, then what are the different disease modifying therapies, then targeted therapies, then what is the scope of hematopoietic stem cell transplantation in MDS. Then, so MDS, it is a actually जो जिनसे आज कहीं सेटा गोटे एंगेजिंग मोड रे हो मैं टॉक कला पे चाहनी ऑलरेडी बहुत जिनसे समस्त जान गेलेनी तो आज मोड टॉक सरला ପରେ ତମର ଏତିକି ଟାର୍ଗେଟ ହବା ଦରକାର କି ଯଦି ଆମ ପାଖକୁ ଗୋଟେ କୌଣସି ପେସେଣ୍ଟ ଆସୁଛି ଏମଡିଏସ୍ ପେସେଣ୍ଟ ଆଟଲିଷ୍ଟ ଆମେ ତାର ପ୍ରପର ଡାୟଗ୍ନୋସିସ୍ ୱାର୍କ କରିବୁ ତାର ଡାୟଗ୍ନୋସିସ୍ ଦବୁ ଆଟଲିଷ୍ଟ ବି ହୁଏ मतलब पैथोलॉजिस्ट हो पेडियाट्रिशियन हो कि मेडिसिन स्पेशलिस्ट हो ତାକୁ କଣ ଟ୍ରିଟମେଣ୍ଟ ଦିଆଯିବ ଆଟଲିଷ୍ଟ ମେଡିସିନ ଡାଟା ମିଳେ ସେତିକି ଦରକାର ଓକେ ସୋ MDS are a group of clonal hematopoietic stem cell disorders characterized by cytopenia, dysplasia in normal neuropathy, major myelodysplasia, inactive hematopoiesis, and recurrent genetic abnormalities, increased risk of developing acute myeloid leukemia. So, ଆମେ ସମସ୍ତେ ଜାଣିଛନ୍ତି actually now এটা change ହେଇଯାଇଛି myelodysplastic neoplasm and cytopenia definition ବି ଆମର change ହେଇଯାଇଛି. Our recommended threshold for dysplasia is 10%. This is the cytopenia threshold already we have actually discussed. So there are actually dysplastic features can be observed either in the form of these erythropoiesis, this granulopoiesis, or this megakaryopoiesis, and these are the different these erythropoietic features to nuclear body, internuclear bridging, karyoresis, multinuclearity, or megaloblastocele changes, thin sideroblast, macularization, fast positivity. Then this granulopoiesis like small or unusually large size hyposegmentation of pseudopelvic anomalies, then nuclear hypersegmentation, hypogranularity, granules, bodies, and horror. So, coming to the differentiation of two Pelzer-Weight anomaly and pseudopelzer-Weight anomaly. Okay, we all know actually what is Pelzer-Weight anomaly, but two Pelzer-Weight anomaly is a congenital condition due to LPR gene mutation. Okay, it is a autosomal dominant mode of inheritance. It is a benign condition, and neutrophil function is normal. There is actually presence of cytoplasmic granules, and more than 80% of the neutrophils they are captured. So how differentiate it from pseudopelzer-Weight anomalies, which is usually seen in case of NPS, AML, CMML, even in case of few drugs or infection that we will discuss subsequently. It is very much important. It is due to LPR gene mutation, and more than 80% of the neutrophils are being affected with this particular anomaly. In two cases, but in pseudo cases, it is variable, often hypogranular cytoplasmic granules, and it is acquired and can be seen in MDS, AML, CMML, drugs, and infection. Then again, two cardiac metastasis syndrome, pseudo-cardiac metastasis. Okay, so it is seen in cardiac metastasis syndrome. Okay, two cardiac metastasis granules. Okay. It is a condition where actually there is inherited listing mutation as a lot of small, it is congenital neurodeficiency, and there is actually different infections, partial ability, then neuropathy, and it is a genetic disorder. But pseudo, again, it is due to acquired dysplastic change in case of AML, MDS, myeloid neoplasms. There is a adenotic granules in the myeloid cells, and there is presence of features of the underlying hematologic malignancy and marker of myelodysplasia or leukemia. So again, you have to differentiate. Then Dole bodies, two Dole bodies, pseudo. Okay, what is Dole bodies? These are actually cytoplasmic inclusions composed of rough endoplasmic reticulum that are classically associated with toxic microbial changes in severe infection. In MPS, similar inclusions like pseudo bodies may be observed as evidence of granulocytic dysplasia. So, two is seen in case of infection as a reactive process, and pseudo is seen in case of MDs with granulocytic dysplasia. Then, this megakaryopoiesis, you can see the micromegakaryocytes, isolation, multiplication. So, coming to the differential diagnosis, जब भी हम काफी सारे पेशेंट के आते हैं जनरल की हमें जानी है एक्चुअली either there is anemia, thrombocytopenia, leukopenia, bicytopenia, okay, or pancytopenia. I mean, so the patient is having actually no hepatosplenomegaly, no lymphadenopathy, nothing. Unexplained. You are actually suspect everything. Then you suspect any of these. One is you start thinking a common cause, not some initial condition. Yes, it is a case of myelodysplastic syndrome. Okay. What are the reversing causes of cytopenia that might actually occur in this particular case? Then other causes of clonal hematopoiesis like leukemia, MDS, MPA, PNH. Then other causes of actually this either CCUS or CHIP or VIMSAR syndrome. So what is VIMSAR syndrome? It is maturation, E3 integration, X-linked and optimal dominant, and this particular syndrome is seen in case of actually young males with this accumulation in case of actually granulocytic series. Okay, so you have to actually keep all these entities as a differential diagnosis. So coming to the reversible causes, these are actually very much important. Research Dr. Ramchandani was asking few cases of actually megaloblastic anemia. They can also features of dysplasia. Okay, so how to differentiate? He was asking many of us are actually maybe unexplained cytopenia cases are being actually given a diagnosis of maybe vitamin B12 deficiency or megaloblastic anemia. So it can actually show features of dysplasia. So vitamin B12 deficiency, folate deficiency, copper deficiency, excess of zinc, causing secondary copper deficiency also. Sometimes it is a case of actually it can cause actually cytopenia and sometimes total dysplasia. Then drug induced changes. Have you ever seen actually a case of actually pulmonary tuberculosis, taking iodines, isoniazid on long term? If you do marrow for anemia, you can see dim sideroblast. Okay, so INH, ganciclovir, tacrolimus, MMF, mycophenolate, chemotherapy, radiotherapy, immunosuppressants, azacitidine, methotrexate. Okay, anticonvulsants like valproate, tacrolimus, mycophenolate, again with linezolid, all these can cause also cytopenia features of dysplasia. Infection, HIV, then parvovirus B19, hepatitis B, C, cytomegalovirus, Epstein-Barr virus, tuberculosis, and severe bacterial sepsis. All these can also cause cytopenia and with or without subtle dysplasia. Autoimmune causes like SLE, rheumatoid arthritis, Sjogren's, adult onset skin disease, then alcohol, benzene, heavy metals like arsenic, lead, all these, and then endocrine metabolic disorders like hypothyroid, liver disease, chronic kidney disease, then congenital dyserythropoietic anemia, then pyruvate anomalies, two pyruvate anomalies, kidney disease. So all these secondary causes they need to be actually differentiated before giving a diagnosis of actually myelodysplastic syndrome or other causes of clonal hematopoiesis. Then leukemia, you can easily actually differentiate after excluding all these causes because you can see the peripheral smear, you can see the tempo of the disease, you can see the clinical examination by actually whether there is any standard tenderness or something like that. Then PNH, again, there is features of actually intravascular hemolysis and this with or without filler, then CCUS and CHIP. So there are actually four entities as far as the liquid. One is clonal hematopoiesis of indeterminate potential, and one is ICUS, one is CCUS. Then CCUS has again been actually differentiated into either low risk CCUS, high risk CCUS, depending upon the genomics. So in CHIP, what happens? There is only associated with clonal markers, either in cytogenetics or in molecular test. But there is no cytopenia, no dysplasia. What is ICUS? As you can see, there is presence of cytopenia. There is presence of cytopenia, but there is no dysplasia. It is idiopathic cytopenia. Okay, so there is presence of cytopenia, but there is no dysplasia, no clonality. But in sickle again, there is presence of actually cytopenia, but there is no dysplasia and there is evidence of clonality. So clonal cytopenia of undetermined significance. So what is low risk and what is high risk? As I was already telling, now is the era of genomics. Suppose you are encountering a patient of sickles and you are ordered actually some genetic testing. In the genetic testing of myeloid disease, you are finding some high risk mutations like T2 mutation, then Epigenetic mutation, ASXL1 mutation, RNX1 mutation, SRSF2, SF3, okay, all these mutations. These are TP53 mutations. All these are actually high risk mutations. These are the patients who are actually to be monitored closely for rapid devolution to either MPS or clonal evolution to acute myeloid leukemia. So you have to be very much cautious. Then another entity as well as already called idiopathic dysplasia of unknown significance. There are actually some cases with persistent morphological dysplasia in one or more hematopoietic lineages without meeting the diagnostic criteria for NDS. So there is dysplasia, maybe the cutoff is less than 10%. Okay, and there is no identified secondary cause, so it can be actually idiopathic dysplasia of unknown significance. So persistent dysplastic changes in bone marrow or peripheral blood, no significant cytopenia. There is no cytopenia, no increased blast, no defining MDS-related cytogenetic or molecular abnormalities, and the exclusion of secondary dysplasia as we have already discussed, it should be the. So then only it can stand with that idiopathic dysplasia of significance. So now, as Sarah already told, there was actually fight between actually WHO 2022 and ICC classification, but now we all are actually unanimously following actually this WHO classification. So it is either genetically defined, either MDS can be genetically defined or it can be morphologically defined. So in the genetically defined population, either it can be MDS with IQ deletion, okay, NDS with SF3B1 mutation and NDS with biallelic mutation. So in NDS with IQ and NDS with SF3B1 mutation, there has to be no other additional cytogenetic or cytogenetic abnormality to be present. It should be the sole criteria. Okay. So it should be the sole criteria. Then MDS with biallelic TP53. What is biallelic TP53? We are actually ordering genetic testing, myelodysplastic. In myelodysplastic, suppose you are actually encountering, there are two mutations in the TP53 genes, two type of mutation. Okay, then it is biallelic. Two alleles are mutated by different type of mutations. Number one. Number two, suppose you are actually finding a mutation with high variant allele frequency, happens more than 50%, you say. Okay, then you can also suspect that yes, it might be actually a biallelic mutation. Then one is actually you are finding a case of actually copy neutral loss of heterozygosity. There are actually two alleles. Suppose one allele is maybe mutated, and that mutated allele is deleted. So that there is actually the number of chromosomes, it remains constant. There is copy neutral loss of heterozygosity. So heterozygosity is lost, and that duplicated mutated allele is duplicated. Okay. So all these comes into the picture of MDS with biallelic TP53. So just to see how actually genomics is playing a very crucial role in MDS diagnosis and therapeutic disease. Okay. Then morphology, MDS with low blast, isoplastic MDS, ID1, ID2, MDS with fibrosis, another entity. Then age in this more than 20%. So it has already been discussed. Then coming to the clinical features and evaluation. Clinical feature कौन है पर जब हम particular patient has either features of anemia, weakness, fatigue, okay, progressive breathlessness, transfusion requirement, okay. Then low blood rate, maybe skin fatigue, purpura, bleeding. Then features of neutropenia, right? Recurrent infections. Then other causes of cytopenia, you carefully exclude. Then you ask history of actually prior transfusions, whether patient has received any blood or platelet transfusion. Other comorbid condition, whether the patient is having any end-stage renal disease, diabetes, hypertension, hypothyroid, or any other medications maybe patient is taking, that can also attribute to this dysplasia. Then you do physical examination. Why physical examination? Because in pediatric patient or young patients who are having actually MDS, there are actually certain other disorders which can actually associated with germline predisposition that we'll discuss subsequently. So there can be extra hematological manifestations. Sometimes there can be actually some underlying morphological anomalies. Okay. So जब हम पाखु गोटे पेशेंट मानिक चलंतु आसी गले ताको हमें कोन करिबा हम फास्ट को एग्जामिन करले ताका क्लिनिकल पिक्चर हम तक पचारले कोन हिची कोन नै से सब जिंस कहले हिस्ट्री देखिले मेडिकेशन हिस्ट्री देखिले तापर देखो कौन हम टेस्ट करेगा नंबर 1 one is history and physical examination is number 1. This is the NCCN criteria 2026. Then CDC complete blood count with examination of the peripheral smear. This is very important. Okay, examination of the peripheral smear. So examination of the peripheral smear is important to rule out many other causes and to look for MDS. Then bone marrow aspiration with iron stain plus biopsy plus cytogenetics by standard karyotyping. Recommended testing of bone marrow sample with reticular stain for fibrosis. Genetic testing for somatic mutation, that is acquired mutation in genes associated with myelodysplastic syndrome. That Sarah already told. Okay, yeah, 69 genes in TMC Kolkata. So isolated bone marrow aspiration, it has no role. Many of the actually centers from periphery, we are seeing that we are doing only bone marrow aspiration. So bone marrow aspiration isolated, it has no role. Always do a biopsy. Be it MDS, be it active leukemia, be it aplastic anemia. If you don't see the biopsy, you can actually diagnose. Okay, sometimes better to not to do actually aspirate. You can take the biopsy and touch print also, but do the biopsy. Then serum erythropoietin acid, if there is a few features of actually transfusion dependency or persistent anemia. Then RBC collator vitamin B12 level, then iron profile, PSH, LDH, then viral markers we have already discussed. Then actually any copper deficiency or malabsorption syndromes, malnutrition, gastric bypass surgery. Okay. पेशेंट ଆମେ ସବୁ ଜିନିଷ ଦେଖିଦେଲେ କରିଦେଲେ ଚାଲ ତାର ଆସିଗଲା ଆକ୍ଚୁଆଲି କଣ ବର୍ତ୍ତମାନ 2 to 3% ବ୍ଲାଷ୍ଟ ଅଛି ମେବି megakaryocytic dysplasia or maybe granulocytic dysplasia ଅଛି you are suspecting some NGS cytogenetics report ଆପଣଙ୍କ ପାଖରେ ଆସିନି କାରଣ ସେଟା 7 ଦିନ ଟାଇମ ଲାଗେ NGS report ଟା ବି ବର୍ତ୍ତମାନ ଆମକୁ 2 ରୁ 3 ସପ୍ତାହ ଟାଇମ ଲାଗୁଛି ସେଟା ବି ଆସିନି myeloid NGS you are suspecting something so now you assess whether actually the patient is medically fit or unfit for therapy ଏମିତି ନାହିଁ ଯେ ଆମେ ସମସ୍ତଙ୍କୁ ଟ୍ରିଟମେଣ୍ଟ ଦେଇଦେବା ତ ଫିଟନେସ୍ ଆମେ କେମିତି ଦେଖିବା we have actually equal performance status, Eastern Cooperative Authority performance status, and one is modified Charleston comorbidity index. एगुडा उसका डिफरेंट पार्ट है एगुडा किसी बुझिया दरकार नहीं पूरा सब ऑनलाइन में अच्छी जस्ट तुम्हें नाटक में रखो सेही हिसाब से पेशेंट को सर्टिफाई करो तो सर्टिफाई करके हम देखते हैं फिट if the epoch is 0 to 2 and Charles CCA is 0 to 2 unfit if it is 3 then if epoch is more than 3 and CCA is more than तो हमारा पेशेंट का फिटनेस स्टेटस फेलिंग स्टेटस का हम पहले असेस करें कौन का इधर असेस करना लगता है बिकॉज़ द ट्रीटमेंट इंटेंसिटी एक्चुअली यू कैन गाइड डिपेंडिंग अपॉन द पेशेंट्स फिटनेस स्टेटस हम पाखरे बहुत सारा थेरापी अछि किंतु एबे द्वारा एक नहीं जे वन साइज फिट्स ऑल हमको पेशेंट रा कोमोर्बिडिटी तार रिक्वायरमेंट तार डिजीज प्रोफाइल जेनेटिक प्रोफाइल सब को देखि इंडिविजुअलाइज थेराप्यूटिक डिसीजन करबा पड़े माने ये वाला कंडीशन नहीं है आज हमको टाइफाइड फीवर आई कि हमें टाइफाइड मेडिसिन नहीं कर मलेरिया आई कि हमको एपिसोडेटिक नहीं करना तो हमको ओवरऑल सब चीज देखि होलिस्टिक ट्रीटमेंट गोटे कॉम्प्रिहेंसिव ट्रीटमेंट प्लान सेटा को हमको डेवलपमेंट करेगा अछि हम पेशेंट को देखिले वर्तमान से केते फिट अछंती कोन अछंती नेक्स्ट जदि हमको 100 टा पेशेंट हम पाखु आसीले एमडीएस समस्त पर एमडीएस समान नहीं समस्त हमको पचास सर हम रोगटा कोन किंतु हमें ताको कोई स्ट्रैटिफाई करिवार अछि एक्चुअली रिस्क स्ट्रैटिफिकेशन दैट इज वेरी इंपोर्टेंट देन हम पाखरे 15 ରୁ 20 वर्ष तले हम देखिबा खाली हम पाखरे न्यारो ब्लास्ट परसेंटेज ना हम गोटे बोन मेरो टेस्ट करथिलु साइटोजेनेटिक टेस्ट करथिलु आ नंबर ऑफ साइटोकिनिया सीडीसी देखु आ किसी पैरामीटर नथला तो सेटा मोस्ट सिंपलर जो स्कोरिंग सिस्टम है इंटरनेशनल प्रोग्नोस्टिक स्कोरिंग सिस्टम IPSS सेटा हम करथिलु जोटा कि लो इंटरमीडिएट 1 इंटरमीडिएट 2 ओके इनिशियल प्रोग्नोस्टिक असेसमेंट प्रेडिक्ट्स CME ट्रांसफॉर्मेशन एंड सर्वाइवल इट बट नाउ after symptom now there are genomics हम पाखरे दीटा जिंस रहू IPSS revised IPSS और molecular IPSS ओके तो revised IPSS रे कोन रहउची हमर बोन मेरो ब्लास्ट होउची साइटोजेनेटिक्स hemoglobin level platelet count absolute hemoglobin count I think in today's era most of the centers they are doing either RIPSS or MIPSS okay MIPSS रे कोन रहउची RIPSS parameter जोरा रहउची साइटोजेनेटिक्स mainly plus if you are sending up a molecular like myeloid NGS, that genomic tag, okay, you are incorporated into the therapeutic disease. Okay, so यही केस का आपको कर करिए आपको आज का ग्रुप रे आपका छोटा ग्रुप रे डिवाइड कर दीजिए MIPSS very low, moderate high, very okay. So it provides molecularly integrated risk prediction and RIPSS most commonly used predictor in the reduced model That's treatment intensity. Because बहुत सारा सेक्टर में आपके molecular testing में प्रोटीन भी पता नहीं खाली cytogenetics करते हैं तो ସେମାନେ RIPSS କରୁଛନ୍ତି ତ ଆମେ ଏବେ କଣ କରୁଛୁ ଆମ ପାଖରେ ସମସ୍ତଙ୍କୁ ଆମେ କିଛିନା standard of care ଆମେ ସମସ୍ତଙ୍କୁ myelodysplastic ତ ଏ ରିସ୍କ ସ୍ଟ୍ରାଟିଫିକେସନ ପୁଣି କେମିତି କରିବା ସବୁ ଜିନିଷ ଆଜି ଶିଖିଯିବ ରିସ୍କ ସ୍ଟ୍ରାଟିଫିକେସନ କେମିତି କରିବା ଗୁଗଲ ରେ କ୍ୟାଲକୁଲେଟର ଅଛି ଆମ ପାଖରେ रिवाइज इंटरनेशनल प्रोग्नोस्टिक स्कोरिंग सिस्टम कैलकुलेटर कैलकुलेटर कौन करियो मैं पेशेंट को सब जहां क्राइटेरिया रहला से मागियो रिपोर्ट देखि हम सेठी दबो यूनिक मॉलिक्यूलर आईपीएसएस एन कैलकुलेटर भी अछि ऊपर तार लिंक देछि सेठी तमे इंटरप्रेट कला माने से कौन करियो पर्टिकुलर तरह रिजल्ट दे दबो पेशेंट को स्कोर करो किछि बुझिया दरकार देन पेशेंट रिस्क स्ट्रैटिफिकेशन हेगा रिस्क स्ट्रैटिफिकेशन हेगला परे नेक्स्ट स्टेप छि हमरा को मन को कहबे कि लो रिस्क को मन कहबे हमें हाई रिस्क दी प्रकार हिसाब से हमारा आसीबो मैनेजमेंट तो जो माने आईपीएसएस लो माने इंटरमीडिएट 1 ने रहिले माने आईपीएसएस आर स्कोरिंग डिजाइन करछंती वेरी लो लो इंटरमीडिएट आईपीएसएस एम वेरी लो लो देन मॉडरेट जदि रहिले से माने को लो रिस्क आ अन्य माने माने इंटरमीडिएट आईपीएसएस इंटरमीडिएट टू हाई देन आईपीएसएस आर इंटरमीडिएट हाई वेरी हाई IPSS moderately high, high, very high, evan to support high risk myelodysplastic syndrome बोली जाए. Then ऐसी बात ट्रीटमेंट तो वर्तमान में पेशेंट को कौन करे देखिए हिस्ट्री दिए करके जहाँ भी हमारा जनरल एग्जामिनेशन करेंगे बोन मेरो एस्पिरेशन सीटीसी पेरिफेरल केयर बोन मेरो एस्पिरेशन बायोप्सी साइटोजेनेटिक्स विथ माइलोडिस्प्लास्टिक पटेले तारा कोमोर्बिडिटी ड्रग हिस्ट्री ट्रांसफ्यूजन हिस्ट्री एवरीथिंग हमें असेस करले देन पेशेंट रा हम कहले रिस्क स्ट्रैटिफिकेशन फ्रेलिटी जोटा फिटनेस स्टेटस हमें इको आउ सीसीआई जेतरे असेस करले फ्रेलिटी करे तारा हम कहले रिस्क स्ट्रैटिफिकेशन करले मे बी बाय आरआईपीएसएस और एमआईपीएसएस रिस्क स्ट्रैटिफिकेशन पर हम पेशेंट को देखले से हाई रिस्क पे अछि कि लो रिस्क पे अछि बुझि परछो केमिति करबा जानिछो कंपैरिजन टूल अछि देन हमको पेशेंट आसिले व्हाट इज द करंट ट्रीटमेंट एल्गोरिथम इन माइलोडिस्प्लास्टिक सिंड्रोम आज के दिन रा कोन तो बाहर कंट्री गुडा रे समान कोन करती आज के दिन रा बहुत सारा माने ट्रायल आसिले सो ऑलवेज इफ देयर इज एक्चुअली एनी अवेलेबल क्लिनिकल ट्रायल इज an option consider clinical trial enrollment for all patients always but in India actually as a last resort so supportive care then transfusion antimicrobial search needed for all patients suppose patient रा बहुत severe anemia अछि specific treatment दवा जो हम transfusion करिबा fever आछि blood culture नहीं कि HRCT करके antibiotic start करिबा हला आगो patient को stabilize करिबा then risk stratification using IPSS-R or now actually IPSS-M supplemented by molecular testing suppose what a patient low risk person MDS and asymptomatic and किछि रो hemoglobin may be around 9.8 9.9 एमती रोची TLC ठीक अछि borderline lymphopenia ANC is around maybe 1500 or 1400 something like that platelet is 97,000 or 1 lakh patient करा actually age होची 60 to 65 years हेलानी ताकू और किछि कोमोर्बिडिटी नाही और मे बी हाइपोथायरॉइड अछि किछि मेडिसिन खाउ जदी अदरवाइज फिट अछि तो सही केस में जदी एसिम्प्टोमेटिक अछंती लो रिस्क अछंती तमे लो रिस्क ऑलवेज रिमेंबर माने साइटोजेनेटिक्स कराइछो सेतले किछि हाई रिस्क फीचर्स किछि आसनी किमा मॉलिक्यूलर टेस्टिंग कराइछो सेतले किछि हाई रिस्क म्यूटेशंस आसी देन यू कैन सेफली कंटिन्यू ऑब्जर्वेशन नो नीड टू गिव एनी ड्रग एसिम्प्टोमेटिक लो रिस्क यू कैन ऑब्जर्व बट एसिम्प्टोमेटिक सपोज हाई रिस्क जदि से पेशेंट रो TP53 म्यूटेशन आछि आर एमआईपीएसएस स्कोरिंग में करछन सेटा हाई आछि तमे से केस रा ऑब्जर्व करबे ओके देन लो रिस्क रे बड़े बड़े कौन सी पेशेंट में आइदर सिम्प्टोमेटिक एनीमिया तो कर जदी एनीमिया अछि विथ फाइटिंग डिलीशन यू कैन गो फॉर lenalidomide because lenalidomide works well with anemia with fighting deletion then anemia with जदी persistent जनगर isolated anemia अछि first test was serum erythropoietin acid so serum erythropoietin if it is less than 500 milli international unit per liter then you go for a trial of erythropoietin stimulating agents like erythropoietin carbopoietin all these agents okay then other causes of anemia suppose you have given erythropoietin stimulating agents or if the ESA is more than 500 and the patient is not a candidate for ESA then in those situations you go for lenalidomide or disease modifying agents with hypomethic treatment okay like azacitidine or decitabine or immunosuppressive therapy in few cases then other cytopenias like thrombocytopenia that the patient has you can give TP receptor mimetics like erythropoietin or myelodysplastic the patient has significant neutropenia then Though GCSF is not actually advocated, but in few circumstances, the patient provides significant fungal infection of from the antibiotic neutropenia, granulocyte with or without a trial of GCSF be the primary. Okay, then high risk mutation is number one priority is always transplant, because all these agents are actually only controlling the disease. It is not curative aspect. Okay, the only curative aspect is allogeneic hematopoietic stem cell transplant. So in high risk cases, always high risk, or those cases of low risk who are actually not responding to conservative management. Those are actually the candidates for allogeneic stem cell transplant. If he or she is a candidate for transplant, you are thinking the patient is fit, there is actually financial problems, there is actually sibling who can actually donate of the, maybe we can go for an autological stem cell transplant, then you can proceed for transplant. And if the patient is not ready for transplant immediately, then you can give a HMA bridge. 2 to 4 मास हम कंपेयर करना कार्डियक स्पेसिफिक नेला का संगे हमरा डेसिडल नेला कुछ मेडिसिन सेकी तापर भी हमें डिजीज बड़ा के कम करी ट्रांसप्लांट टाइम नहीं करी देन नॉन ट्रांसप्लांट कैंडिडेट जो ऑप्शन की मानकर एल्डरली कोमोर्बिडिटी फेल असंती इन दो cases you can continue HMA with supportive care until disease progression or unacceptable toxicity. Then coming to the practical use, you see of erythropoietin stimulating agents. Usually, erythropoietin stimulating agents is given in low risk IPSS cases with isolated anemia or symptomatic anemia or transfusion dependency, and the body should have actually adequate iron stores. If we have erythropoietin stimulating agents, those in body iron deficiency anemia, that is hemoglobin spike up above that. So erythropoietin by हम कहते हैं dose करकर E14 you can give actually around 30,000 units per week, or rabopoietin you can give around 150 to 240 micrograms per unit. Then maximal dose you can go till actually 300 micrograms rabopoietin per week. And erythropoietin ना कितने दिन कंटिन्यू करिए. फॉर एग्जांपल जोड़ो तो अपना erythropoietin पर rabopoietin दो दिन तक hemoglobin बढ़ू. तब तो जीवन जगह में कंटिन्यू करके रख करिए. ये तो करिए कि मेडिसिन का काम करना है. At least you have to give actually 16 weeks at the highest dose. हाईएस्ट डोज रे जब आपण 16 सप्ताह माने 4 मास पता कि देलेनी तथा भी पेशेंट रो हिमोग्लोबिन बढ़ुनी देन आगु कल देखि फायदा नै वी कैन थिंक ऑफ सम अल्टरनेटिव देन again low risk MDS you see risk classification according to IPSS or IPSS name. If it is a low risk MDS, then isolated anemia, serum erythropoietin is more than 500. Okay, no response to erythropoietin stimulating agents, then you categorize as follows. If it is hypocellular MDS, what is hypocellular MDS? That is also a separate entity that I have discussed. By actually, there are some cases of actually MDS who are actually mimicking like aplastic anemia. The marrow is actually hypocellular, less than maybe 20%, 25% as per age. But there is features of subtle dysplasia. So in hypocellular MDS, it has been seen that pathogenesis is due to a cytotoxic T-cell mediated allogeneic T cells which are actually damaging the bone marrow stem cells, leading to ineffective erythropoiesis. Okay. In those cases, you can give actually immunosuppressive therapy with ATG and cyclosporine with or without eltrombopag. So IST is younger and more adverse cytogenetics feature. That is hypocellular MDS can go for a trial of IST. But the result of IST in hypocellular MDS as compared to aplastic anemia is inferior. Okay. Then cytopenia जब अच्छी वाला पेशेंट रहा हमें तब ट्रांसफ्यूजन दवा MDS with ring sideroblast with transfusion dependency जब हम पहला ring sideroblast यदि आसी गला ता संगे पेशेंट रा anemia अच्छी आज का दिन हम पाके मोडे मेडिसिन अच्छी जोटा को हम कौन कोचे active immune receptor agonist that is luspatercept. Okay, तर ट्रायल हम सेंटर में चली थी राजीव गांधी रे तो luspatercept you can also give. Drug is actually very much costly, but yes, this is approved. Then deletion 5-2 MDS with transfusion dependency. What is the drug of choice? This is a very quick question. Drug of choice for MDS with 5-2 deletion is very good. Then I will know. MDS with 5-2 deletion. Again, what is the pathogenesis? You should actually read. What is actually haploinsufficiency of RPS protein? And how that haploinsufficiency actually increases the susceptibility to lenalidomide. All those cases actually you have to read. Then give lenalidomide clinical trial. Then if patient is not responding, then you have to whether he or she is a candidate for hematopoietic stem cell transplantation. And in high risk cases, say either you can go for hematopoietic stem cell transplantation or HMFS reaching followed by hematopoietic stem cell transplant. So some approved drugs for MDS, what are new drugs actually currently approved? So one is luspatercept, activin receptor ligand trap, enhances late stage infant maturation. Then one is imitalostat. Okay, it is a telomerase inhibitor currently approved. Okay, it is approved for low risk MDS with calcium dependent anemia after ESA failure ineligibility. Suppose ଗୋଟେ patient hypertension ଅଛି, କୋଉ ଜାଗାରେ DBT ଅଛି, anti hypertensive ଖାଉଛନ୍ତି, unexplained actually ତାଙ୍କର hypertension ରହୁଛି, ବେଶୀ ରହୁଛି, accelerated hypertension. Stimulating agent very much caution. Then in those cases you can give this particular drug, imitalostat. Then as Sarah report, IDH1 inhibitor like ivosidenib, bedacidenib, we have actually all these targeted agents. So ଯଦି ଆମେ genetics କରିବା, molecular genetics myelodysplastic ପଠେଇବା, ତାହେଲେ ଆମେ IDH1 inhibitor, IDH1 mutation को diagnosis କରିବା, ये medicine ଟା ଦେଇପାରିବା, କାରଣ ଆଜିକା ଦିନରେ ଆମ ପାଖରେ ଏଇ ସବୁ medicine ଅଛି already. Then lenalidomide, it is a immunomodulatory drug, selective effector IQ clone, but in some circumstances ଯଦି ତମେ patient ମାନଙ୍କର conservative treatment ଦେଇଛ, you can add lenalidomide in other cases also. Then azacitidine and decitabine, these are actually DNA methyl transferase inhibitor or cytomethylating agents, which are actually approved for either maybe refractory cases of actually low risk MDS or high risk MDS. It includes survival, which is the standard first line disease modifying therapy, and then venetoclax, recently approved in BCL2 inhibition in high risk MDS with maybe specifically with excess blast. What a AML patient upon the question, two connector blast to around bone marrow blast 5 to 19%. MDS IB2. Okay. So IB2 the 12% that NPT, ICC classification is MDS/AML. So it is a very mathematical. So those cases you have to treat like actually AML. So say cases have to azacitidine with venetoclax. तो आम हॉस्पिटल बहुत सारा केस आछी, बहुत केस आनी बाकी बहुत चिंता केस डिस्कशन करछि. नंबर 1 is unexplained anemia in elderly. Early referral is no clues for good diagnosis. এটা হচ্ছে আমরা আজি সেই কেস. 56-year-old male presented with a tape fatigue, progressive exertional restlessness, no fever, rash, bleed or any other comorbidity, no hepatosplenomegaly or lymphadenopathy, received 2 units of blood transfusion, CBCMC there is mild anemia, usually 8.1, platelet is normal, PLC is normal, MCV is 102, electrolyte LDH is normal, PS you have seen actually microcytic, there is macrocytic anemia, the iron profile B12 is normal, received a therapeutic trial of vitamin B12, locally knowledge, and डॉक्टर पास कौन कर जाएगा नेचुरली यदि अच्छी सब जिन सब देखले नॉर्मल चलो मैक्रोसाइटिक एनीमिया अच्छी ओले विटामिन B12 पर ट्रायल देखि देखियो तो देले देयर इज नो इंप्रूवमेंट डिले बोन मैरो एंड इन द बोन मैरो वी सी मैरो वाज एक्चुअली हाइपरसिमिलर marked in megakaryocytic hyperplasia with presence of many small and hypolocated forms. Can you see these hypolocated megakaryocytes? So serum erythropoietin it was actually 382 internal for anemia. Since why did you actually do the serum erythropoietin? देखो ताकर actually खाली isolated anemia अछि और किछि complex जेहेतु anemia अछि with bone marrow showing pictures of megakaryocytic hyperplasia and the anemia थिबो you do a serum erythropoietin because some pathogen of CSA जति सेटा 5 पॉइंट आसीला अछि ताकर केते अछि 382 then we send a karyotype कोन अछि ताकर high risk देखंतु abnormality like deletion 7q. Okay, it is a MDS defining cytogenetic abnormality as Sarah showed that in particular table. So the diagnosis was MDS low blast or IPSS. Hala intermediate. So diagnosis हम करियो सबमिक्स ऑफ MDS low blast WHO से diagnosis कर देला कैलकुलेटर पर के तमे डिस्ट्रैटिफाई कर. Then started on weekly erythropoietin जेतु ताकर माने एनीमिया अछि ये से ताकर कम अछि erythropoietin ता तो erythropoietin हम स्टार्ट करियो एनीमिया इति. Then 3 वर्ष पर कोन हला कि एनीमिया अगेन रिकॉर्ड after the anemia and bone marrow showed 11% myelodysplastic on flow with persistent megakaryocytic dysplasia. NGS this time we not done. During that time actually NGS was not done. Now NGS showed actually ASXL1 mutation, TEC2 mutation. And now MDS IB2 with IPSS-N. It is high risk. Okay. Now we have calculated the IPSS-N. So currently now we have started azacitidine and the anemia improved after 4 cycles. Okay. Bone marrow in remission, we have done the AML MRD type of thing. MRD is negative and received reduced intensity conditioning match sibling donor, allogeneic hematopoietic stem cell transplant from it actually brother. then the patient is actually doing well 3 years post HSCT without any complications. You can imagine the case of actually MDS, 56-year-old, we have given a quality of life, okay, by actually initially giving ESA by proper workup. Then after 2 years, even after he progressed to AML, we have done actually given azacitidine, then transplant. Post transplant 3 years he is doing well. So this case teaches us a lot of things. So unexplained anemia needs to be evaluated properly for correct diagnosis and therapy. Case 2, non-Sambalpur. Okay, dyspnea regression. 3 months with fatigue, progressive swelling of both dwelling, 6 to 7 months, CBC, there is anemia, NCB 104, you see PL6 2186, and improving 50, platelet is 95,000, PS occasional ovalocytes, hypertension, hypothyroid as comorbidities, received 7 days of injection methylcoalamin due to macrocytic anemia, serum vitamin D3 was around 787 baseline. Okay, then anemia persisted. Bone marrow test, it showed actually megaloblastic dysplasia, no increase in immature cells, bone marrow aspiration, and biopsy showed 1% blast. NDS piece we have done. NDS piece showed 5q31, 5q33 deletion. So 5q deletion जोटा আমি কହୁছে সব জায়গা যদি আমার 5q মানে আমরা deletion হয়ে গেল সেটা আমি করব typical leukocyte 5q31 to 33. Okay, if that particular leukocyte is actually deleted, then it is 5q deletion. But এই কেসে দেখুন টাকা আছে 5q31 to 33, but it should be isolated. There should be no other actually cytogenetic abnormality. It is packer kanachi 20q deletion. So it is not a case of MDS with 5q deletion. Okay. So then we did the cytogenetics again. Cytogenetics showed actually deletion 5q, deletion 20q with complex cellular translocation T12, and we sent the myeloid NGS. And myeloid NGS you see it showed actually 50-53 mutation with a high variant allelic frequency. It is around 53%. Maybe a case of allelic 53 mutation. Okay. So diagnosis of myelodysplastic neoplasm with mutated 53, 1% plus with complex karyotype, including deletion 5q, all these entities. And as far as the restratification, he was an IPSS-R intermediate, IPSS-M, moderate high risk. We actually offered hematopoietic stem cell transplantation, but the patient was reluctant. So he was not ready for actually hematopoietic stem cell transplantation, though he was actually fit. But we started actually again cycle 1 azacitidine as per protocol from 3rd of January 2026, and now actually receiving 6 cycle of azacitidine. Okay, and the patient is actually doing well. It's improved, platelet is normalized now, and again PLC also normalized. But I have already clearly counseled the patient. Yes, we are giving you a symptomatic treatment. It is not the curative treatment. Giving on azacitidine, your TP53 clone can progress anytime, and it can anytime actually progress to acute myeloid leukemia. Then case 3, 52-year-old female, symptomatic from 3 months, fever, low grade, head reeling, associated with low back pain, low appetite for 5 months, comorbidity, cholecystectomy 2019, old pulmonary tuberculosis 15 years before, concentrated at a valley store, then at doctor. Current issues when coming to our hospital, fatigue, constipation, perianal pain with actually perianal fissure, low appetite, diarrhea, low cough, fever, bleeding, CBC, there is severe anemia. Okay, severe thrombocytopenia, 18,000, hemoglobin 5, occasional circulating blast. Then bone marrow biopsy, it showed actually 14% myeloid blast. So a diagnosis of MDS with IB2. And cytogenetics we have done actually, it was actually failed. And this myeloid NGS we have done, it showed PTPN mutation, and the IPSS was very high. So again, in this particular case, we have given azacitidine with venetoclax. Okay, 7 days azacitidine with venetoclax as per this recent trial, and anemia, thrombocytopenia, led to pneumonia. During actually this adjuvant chemotherapy, she developed actually profound leukopenia with fungal pneumonia, transfusion dependency. She remained admitted in the hospital for 1.5 months. Okay, under the PM2 then subsequently her count recovered. Okay, febrile neutropenia now counts recovered. Currently on cycle 2 azacitidine venetoclax from 22nd of June 2026, and the last CBC we can see hemoglobin is 10.5, PLC is normal, platelet is 4.5. So ideally this case should actually undergo hematopoietic stem cell transplantation after maybe 4 to 6 cycle of azacitidine for a curative mutation. दूसरा साइड साफ नहीं हो और ठीक है छाड़ा तो वर्तमान जारी हो वर्तमान लास्ट को करें हम ठीक चाइल्डहुड एमडीएस ऊपर जस्ट थोड़ा 5 मिनट्स डिस्कस करके फाइनल करेंगे तो चाइल्डहुड एमडीएस जो एमडीएस इज डिजीज ऑफ एल्डरली वो छोटा पिला को भी हमारा एमडीएस हुए तो इट इज चाइल्डहुड एमडीएस so childhood MDS the clonal hematopoietic stem cell neoplasm arising in children and adolescents leading to ineffective erythropoiesis cytopenia and risk of progression to AML. So already start function data it may be either hypocellular childhood MDS or childhood MDS not otherwise specified or childhood MDS with increased blast. If the blast is at 5 to 19% from the bone marrow or 2 to 19% from the blood marrow. So childhood MDS rate typically हम जब देखिए monosomy 7 deletion complex karyotype एवं सब most commonly देखा जाए. Acquired cytogenetic abnormality जो देखिए typically RAS pathway mutation. These are actually most commonly childhood MDS and छोटो छुआ जदि गोटे MDS हला ताले कोन भाबिबा जे सेटा हम कहथिली the most important thing is a subset of myelodysplastic syndrome in pediatric MDS or MDN. You always have to rule out germline genetic mutation that predispose the individuals to bone marrow failure and myeloid neoplasm. Family रे किस तरह germline defect already ongoing अछि जोटा कि वर्तमान पहुंचला early manifestations होछि काहे जे करिबा सेटा इंपोर्टेंस कोन these are actually different inherited syndromes that predispose to myelodysplastic neoplasm as pediatric MDS पर तो बड़ा पेशेंट का फंक्शन को डाटा टू डेफिशिएंसी अछि RNX1 familiar platelet disorder with predisposing to myeloid malignancy. Then familiar MDS AML with SEPA mutation, dyskeratosis congenita, Fanconi anemia, SDS. Then familiar MDS or AML with DDX1, DDX41 mutation, 79L syndrome, severe congenital leukopenia, renal syndrome with predisposition to myeloid neoplasm. So all these are actually different germline predisposition syndromes which can actually manifest as early pediatric MDS or acute leukemia. So जल्दी जन को 50% कम 50% कम 40% कम हेले तो देखिना कि 50% की यूनिट जति कम अछि यंग लोक को तमे देखुछ एक्चुअली जणकर सेकेंडरी कजेस किछि नै एमडीएस अछि ऑलवेज रूल आउट दिस कजेस काहे कि एटा रूल आउट करियो तो ना डायरेक्टली ट्रीटमेंट स्टार्ट कर दबा असुविधा कोन अछि काहे कि when to suspect जेतबे सस्पेक्ट करिबो germline predisposition MDS diagnosed at a young age less than 50 years family history of MDS ताको फैमिली रे आउट आउट MDS अछि नगर ब्लड कैंसर AML अछि not unexplained कारण thrombocytopenia अछि anemia अछि leukopenia अछि so that might be actually same case okay lifelong cytopenia or abnormal blood count okay ताको रोंची congenital abnormalities किछि दिन देखला किछि morphological abnormality अछि maybe short neck एला Fanconi रो किछि एला SDS रो किछि एला एमडी अछि unusual cytogenetic findings like monosomy 7 अछि ताकर उडे pediatrics रे बेसी देखा जाय then poor tolerance to standard chemotherapy or transplant condition किछि chemotherapy दोछ जहा कि कोनसा excess toxicity अंदर लोग माने जे टॉलरेट करछन से भला टॉलरेट करि करना काहे कि बेसी टॉक्सिसिटी देखो Fanconi anemia रे क्रोमोसोमल ब्रेकेज एनालिसिस कलेक्ट ड्यू टू क्रोमोसोमल इंस्टेबिलिटी देयर इज टॉक्सिसिटी जे वजह कैसे माने बेसी टॉक्सिसिटी ना से केस तमे काम करिवो सस्पेक्ट करिवो तो सस्पेक्ट कला पे क्लिनिकल इंपोर्टेंस कोन ए केस को सस्पेक्ट करके डायग्नोसिस करिया कोन दरकार माने कि हमको आमे से पेशेंट को बोन मेरो ट्रांसप्लांट करी तार भाई को हम मात्र डोनर हिसाब नै जीवा तभी तार भाई भी सही से चढ़ाई अछि जब लाइक डिस्पोजिशन हमें ताको डोनर हिसाब नै की ताको कंडीशनिंग देगी तार स्टेम सेल देले तो पेशेंट को हमें नॉर्मली से डिजीज स्टेम सेल इन देले so selecting appropriate stem cell donor avoid affected relatives diagnosis କରିथिबो germline predisposition ता नै आइबो ना adjusting conditioning regimen जदि एबला केसेस अछन तमे हाई इंटेंसिटी कंडीशनिंग रेजिमेंट मान को अपन टॉक्सिसिटी बेसी हो ओके बिफोर ट्रांसप्लांटेशन देन यू कैन स्क्रीन अदर फैमिली मेंबर्स आल्सो provide genetic counseling and improve long term management out okay then last slide that is hypoplastic MDS so what is the difference between hypoplastic MDS and aplastic MDS so hypoplastic MDS this is hypoplastic MDS first it is a clonal myeloid neoplasm but aplastic anemia is a non-neoplastic immune mediated bone marrow failure okay cytotoxic severe T cell mutated allogeneic T cells that damages the bone then dysplasia in hypoplastic MDS there is presence of dysplasia but in aplastic anemia there is no dysplasia blast may be increased in case of hypoplastic MDS but it is usually not increased in case of aplastic anemia then cytogenetic abnormality it is actually common monosomy 7 deletion 72 trisomy 8 anything MDS different cytogenetic abnormalities but aplastic anemia usually have a normal karyotype but it can find some actually cytogenetic abnormalities also like trisomy 8 monosomy 7 there is somatic mutations you can find many of the somatic mutations in hypocellular MDS but usually less common in case of aplastic anemia PNH clone usually uncommon or very small in case of MDS. Okay, hypoplastic MDS, but it is more common in case of aplastic anemia. The risk of AML transformation is significantly high. Okay, but in aplastic anemia, it is actually low. Then response to immunosuppressive therapy. Suppose you have given some trial of ATG cyclosporine with erythropoietin. In aplastic anemia, the response is usually good as compared to hypoplastic anemia. So this is actually the concluding slides. That is summary. So this stress treatment, that is management, is guided by prognostic risk always. IPSSR or IPSSN, patient age, comorbidities, symptoms, and treatment goals. Supporting care like blood transfusion, platelet transfusion, iron chelation. Suppose when a patient बहुत सारा blood कौन सी creatinine acid more than 1000 के इंटरनल तक blood दे चलेगा. Iron overload भी केवल prevent करेगा. By declaration death reaction that is also indicated in MDS. Then infection prevention, growth factor, then low risk MDS study also be erythropoietin stimulating agents with active deletion find. I mean retinal data. High risk MDS study also be digital agents to the adjacent and respiratory. The standard of care, then targeted therapy. Molecular testing now up to evaluate allogeneic stem cell transplantation. It should be actually provided to high risk cases in appropriate scenario and follow-up monitoring to be done with regular assessment of blood count, treatment response, disease progression, quality of life, and management of related complications. It is the essential. Thank you. Going to some further class, there instead by one topic, but যেহেতু মানে আন্ডারগ্রাজুয়েট স্টুডেন্টস পোস্ট গ্রাজুয়েট স্টুডেন্টস অଛନ୍ତି ତାକୁ ବହୁତ ପିସ୍ କରିକି ସିମ୍ପଲ ଲାଗେନି କହିବା ପାଇଁ ଅଲରେଡି କୁଇଜ୍ ପରେ ସମସ୍ତେ ଷ୍ଟ୍ରେସ୍ ହେଇକି ଅଛ ତ ଭାବୁଛି ମାନେ ଆଟଲିଷ୍ଟ ବେସିକ୍ ଜିନିଷ କିଛି ଯାଇଥିବ ଥ୍ୟାଙ୍କ ୟୁ
Any queries or any doubt? Query. Okay. Thank you, Dr. Vikram. Really nicely explained. It's a difficult topic, but he actually given us so much of knowledge. So that at least in our level, we can basically guide the person how to do, what to do, and where to do. All these things we can guide. And we are also coming to support for this. Okay, one. But this is a thing that we and idea of the team. They are doing something of area, but we can but the first Friday, everyone has to be that number of duty. It is a very nice thing. Very happy that one. Actually, so this of Mila for injective and for exam.
Prognostic significance of LDL because we Myelodysplastic Syndrome actually in relation to REG 1 and 2.
Properly studying MDS because I have given the establishment of prognostic model. Which is fully standard, but there is a change. It is the marker of a similar term. Okay. So my team needs to be studied. This how
There are two or three studies because found that it has a prognostic implication only REG 1 and 2.
Actually, it is gone beyond RNP and RNP to the cytogenetics and genetic analysis.
But some set of these are
So forget about LDL. Try to record or establish facility this particular.
Thank you, Dr.
Thank you. Thank you, Dr. Kanda, for the excellent practical insights with such elaborate discussion. I now request Dr. Kumar sir to present the conclusion to Dr. Kanda. Thank you, sir. Now let us move towards the last session, the scientific session by Dr. Virendra Banerjee, sir. To introduce Dr. Virendra Banerjee, founder and MD in INGNA Life Science and head JGS Health Center for Molecular Medicine, Silicon University, Bhubaneswar. He has done PhD in cancer biology from University of SYASS, Bangalore, and Department of Medical Genetics, Manipal Hospital, Bangalore. PhD Crest, Government of India Fellow, with the Baylor College of Medicine, Houston, USA. Bioentrepreneurship Fellowship at Rice University, Houston, USA. Such lots of awards and recognitions, including Young Scientist of the Year 2003, EBTGO IPS Award 2013 to undergo fellowship. He was selected under 40 young leaders by Stein and Bain Foundation, Switzerland 2017. Indian Express 40 under 40 delivered award 2017 and Best Delivery Award by SRNC SRIHER University, Chennai. So he is not present here physically. He will be seeing his lecture delivered by him through Zoom. So, let us
Hello. Is my slide visible? Just respond yes or no.
Yes, yes, yes.
Hello. Hello. You are muted. Unmute and for my slides.
ऑडियो का है ऑन कर दे
Hello.
राइट साइड पे कलर कर ओके ओके
See my slide.
यस
Right now I am not doing. Yeah, can you see that? Hello. Okay, so let's start. Okay. So good evening, everyone, and this is Kiran Banerjee. I'm from Indian Life Sciences, Bhubaneswar. I thank Professor Sunanda ma'am, Professor Sahul, Alka ma'am, for giving me this opportunity to join you in this wonderful meeting. Apologies not to come physically because of pressing important urgent need here, but nevertheless, I'm very happy to be here. I'll be just talking about few epigenetic drivers today evening, which drives the Myelodysplastic Syndrome. So the epigenetic landscape, there's a little difference. It precedes the genetic changes. We have changes in the DNA or the histone with our environmental exposure, and these sequences get altered epigenetically, and there are cell fate where the myeloid lineage is very important to become each cell is affected, and the clonal selection for each cell is disturbed by this epigenetic landscape. So just to give a brief idea about what epigenetic is, we have genome, we have epigenome, and there's a dynamism between epigenome and genome, where we have the environment playing a big role. So our food, nutrition, exposure to different microbial pathogens, radiation, toxin, they all are switching on and off our genes epigenetically all the time. So we have few epigenetic markers or epigenetic mechanisms. The most commonly known is DNA methylation, and there are DNA methylating enzymes like DNA methyltransferases, and we have X, then we have histone, extension, and methylation. So there are certain histone models. Histone is a core protein which binds our DNA, and histone can be also modified that can also silence your genes. So basically, a gene can be silenced by methylation, and if you do hypermethylation, more genes will be silenced. But if we do hypomethylation, the genes will be triggered and there will be continuous expression. So basically, there are different epigenetic modifiers. Today, I'm not going to go into details of most of them, but some of them are which are associated with myelodysplastic syndrome. I'm going to touch upon them. So, as a pathologist, there's a paradox. When a pathologist examines bone marrow and the profile suggests hypercellular active proliferation, which is the hallmark of pathogenic effect in MPS, there's a catastrophic block actually in the cellular differentiation process. And this differentiation and accelerated apoptosis is actually triggered by epigenetic modifiers or epigenetic drivers. Which are these drivers in myelodysplastic syndrome? Let's say. So there are DNA methylation pathways which is happening in somatic cells. That is DNMT3A, which is the DNA methyltransferase, and TEC2, which is also altering at the cytosine depletion level. So this basically we have the four bases: the cytosine, guanine, tyrosine, and thymine. So here the cytosine is methylated, sometimes hypermethylation, which silences the gene, or hypomethylation, which enhances the gene and arrests the normal function. We also have chromatin modification, where the histone proteins like XPK27 is methylated, or polycomb repression complex is also modified at the structural level of the genome. So this is the histone proteins. This cartoon tells about how histone proteins can be repressed by acylation or activated by hydroxymethylation or hypomethylation. So the early landscape drivers in MDS is DNMT3A and TEC2, and they also get dysfunctional as we age, which I'll just tell you in a minute. DNMT3 loss impairs the methylation process, which leads to hypomethylation and uncontrolled stem cell proliferation. TEC2 loss, it disables the DNA demethylation and causes again hypermethylation and also silencing of some of the important tumor suppressor genes, and in fact promote the carcinogenesis process. And there is also splicing or linkage skewing, which actually suppresses the healthy erythropoiesis or differentiation of our myeloid cells during the formation development of the cells. So 90% of MDS patients have somatic mutation. If we do next generation sequencing or NGS, there are 90% of MDS patients which carry at least one driver somatic mutation at the epigenetic level. These mutations can be methylators, this can be RNA splicing, or can be chromatin modifiers. So, as I told, there are DNA methylators, there are chromatin modifiers like ECS2, polycomb repressive complexes, SPK27, and also there are splicing complexes which splice the DNA for making misfolded proteins. So the landscape looks like this, that there are 5C methylation at the cytosine, level, and TEC2 loss directly prevents the oxidation of 5-methyl cytosine and thereby arrests the primary activation of demethylation pathway. And thereby this loss actually silences the tumor suppressor genes. Then there are promoters hypermethylation, which promotes global gene silencing, because hypermethylation always leads to silencing. And then there is also selective clonal expansion of skew cells, which are pre-leukemic stem cell pools, which keeps on enriching. So these are some of the important catalytic epigenetic chaos which happens early in MPS syndrome, which we do not see in pathology when we see it. If we do AGS or epigenetic profiling, then we may detect them early. And TEC2 mutation is very highly prevalent in MPS subtype. Then the methylation defect is a de novo process. It happens during the lifetime, and it can be catalyzed by many factors, including diet, including lifestyle, including exposures and aging. And there is a very important metabolic hijacking for students. If you are listening, the students, please note that in our pyruvate cycle or glucose metabolic pathway, you have an enzyme called acetyl-CoA, and that is transferred into alpha-ketoglutarate. There is a protein, there is a gene called IDH1. It operates in the cytoplasm and it converts the isocitrate to alpha-ketoglutarate. Now, if this gene is mutated, then there are alpha-ketoglutarate gets into oncometabolite called 2-hydroxyglutarate, 2-HG. Now, this happens in cytoplasm. Now, this 2-HG then transports itself to mitochondria and gets accumulated there. And if there is too much of 2-HG accumulation, they actually mimic the condition of TEC2 mutation, which I told earlier. You need not have a TEC2 mutation, but if you have an IDH1 mutation and accumulation of 2-HG, it will mimic what TEC2 mutation does by generating severe hypermethylation profiles of tumor suppressor gene and driving the tumor. So mitochondrial oncometabolic accumulation of IDH2 mutations can happen at various stages, and this will form accumulation of excess of 2-HG, as I told, and there will be block in erythroid differentiation process. So this is very important before we see any DNA mutation or any gene mutation. Epigenetic modifiers takes place. So to summarize, there are 4 important epigenetic modifiers which contribute about 80 to 90% of epigenetic mutation in MDS. One is TEC2, loss function leads to DNA hypermethylation. They actually respond to therapy if you give them hypomethylating agents, because there is a hypermethylation in the system. If we give hypomethylating agents like HMAs, then there will be a favorable response by the patient. Then AXL1, which disrupts the chromatin complex or structural histone complex, there if we actually that creates a lot of adverse prognosis. Prognosis is not good, and there is a DNMT-A3 and loss of PZA2. These are the 4 important epigenetic drivers which contributes most of the epigenetic changes in MDS. So there is a new concept called clonal hematopoiesis or CHIP, where accumulation of somatic epigenetic mutation over ages in different decades of anybody's life, the second, third, fourth, fifth decade, when they accumulate this pre-leukemic condition, then there are different clones which are selected, and later on they tend to transform into Myelodysplastic Syndrome, or what we call as MDS or AML. So how do we target them therapeutically? As I told you, there are hypomethylating agents called HMAs, which are azacitidine or decitabine. They are frontline standard of care, but basically they are doing the hypomethylation, because if genes are silenced, tumor suppressor genes are silenced. If we can reactivate it, then the tumor suppressor gene gets activated. Then there is cytidine analogs, which binds and degrades the DNMTs or DNA enzyme transferases, which restore the expression of critical tumor suppressor genes. And there are new combinations coming up now against IDH1 and 2 mutational pathways. These are all important excitement in the epigenetic modification of treatment of MDS now. And thank you so much. This is my group from Indiana. Before I leave, I just would like to advertise that we have started a novel department, first time in Eastern India,
Department of Molecular Medicine, where we are offering MSc in Molecular Medicine and Clinical Medicine. In my view, if we believe what we are doing, and then we will definitely succeed, because improvement of mankind is our goal, and genetically, epigenetically, if we can improve ourselves, we will succeed in our path of clinical relevance. That's what Rosalind Franklin told, the discoverer of DNA structure. This is my first batch of JBS Talent Center for Molecular Medicine students. Thank you very much.
Thank you so much, sir. Thank you.
Only a few people were there. Have any questions?
Thank you, sir. For your nice informative lecture. We got very novel information. It was quite novel informative lecture. Thank you. Okay. Thank you for nice gesture. We miss you, sir. It's all. Yeah. You listen now. YouTube. Okay. Oh, we'll send the memento and certificates and bouquet, everything. Okay. Most welcome, sir. Most welcome. As we come to the end of the scientific session, I would like to request Director Sir to felicitate all our chairpersons. I request Director Sir to felicitate Professor Dr. Alka Sahu ma'am. Now I request Professor Dr. Bhavani Ratha Sir to felicitate Dr. Murmu ma'am. Now I request Dr. Swami Sir to come and felicitate Dr. Sushant Kumar Behra Sir. Now, sir, thank you, sir, for just a minute for vote of thanks by our organizing chairperson. I invite Dr. Alka Kaufman to kindly deliver the vote of thanks.
मेरे मुंडे गया अच्छा
Members, dear present, very good evening to all of you. My talk today propose total thanks on behalf of the Department of Pathology for that. First and foremost, I express my heartfelt gratitude to all our esteemed speakers, Professor Dr. Mohanty, Dean Principal Burla, Dr. Pradeep, Minister, Director, SSCR, Professor, Vandana of Indian MDS Registry. Sir, thanks a lot for giving us precious time. In spite of your busy schedule, we are all really honored to have you. Dr. Srivinkam Pandal, consultant, Clinical Oncology, NBMT, PSSCR, Professor, again an alumni of this institution. Thank you, sir, for sharing your valuable knowledge and insights on the recent updates in MDS. Dr. Virendra Banerjee, founder and MD and DNA, Life Science and Head, ATS Talent Center for Molecular Medicine, Cleveland University Professor, with special interest in human genetics. All your enlightened presentation have enriched our understanding of the latest advances in diagnosis and management of MDS and all undoubtedly benefit our clinical and academic practice. I extend my sincere thanks to our respected chairperson for expertly conducting the scientific sessions and facilitating meaningful discussions. Our deepest gratitude goes to our respected Director Professor Dr. Almond Naik sir, Dean and Principal Professor Dr. Pradeep Kumar Mohanty sir, for their constant encouragement, guidance, and support in this CME exam success. I would also like to thank all the faculty members, postgraduate students, delegates, and participants for your enthusiastic presence and active interactions, which truly made today's academic events vibrant and productive. A special word of appreciation goes to organizing secretary, Professor Dr. Yandalai, all the members of organizing committee, volunteers, and the technical and administrative staff, whose tireless efforts behind the scenes ensured smooth execution of the program. Finally, thanks everyone who contributed directly or indirectly to the success of this CME.
Last but not the least, I thank God, the Almighty, for this divine blessings to conduct this CME successfully. We hope today's deliberations inspire us to continue learning, collaborating, and providing the best possible care to our patients. I conclude my vote of thanks saying, Sarve Ubantu Sukhinam, Sarve Santu Niramaya, Sarve Vandani question to Mohanty Kumar Pradeep. Now all of you, please proceed for the request. Waiting for you. At least make your safe journey. At least dinner service comfort and thank you once again. Thank you.